welcome to Newcastle. Of course, being the network of excellence in pharmacogenetics and medicines optimization, we wanted to jump onto the success of the local team winning a trophy for the first time in 70 years. Of course, my team duly sort of completely capitulated in the final just to make sure everyone was happy in the Northeast, so that's very good. And so, first of all, before I do anything, I'd like to thank Emma Groves and the team for hosting us and for all the energy and effort today. So, a couple of things. If you hear a fire alarm, it's real. And so, be calm and walk out that way or that way. I think, yeah, that sounds good. Like, not very good if oxygen falls and all that sort of stuff. Okay, so you can see the complimentary Wi-Fi. Right, that's me. This is the third of these meetings. So we had one about a year ago in Liverpool to kick everything off. And actually, in the coming days, there will be a paper that will be published around some of the outputs from that meeting and how that is sort of building on some of the work that Munir and colleagues have done previously and sort of seeing the direction of travel now that the network of excellence is in place. So John McDermott and Maria, so John obviously here, you'll hear from a little bit later, but I've led that with Munir. So I think that'll be a really nice output and we'll share that with all the delegates when that's out in the coming days. And then, of course, we had a meeting in London at the end of last year, which was really great, and, of course, here today. So for those of you, most people I see, sort of familiar faces, but there may be a couple of people in the room a little bit less familiar with the Network of Excellence in Pharmacogenetics. This is funded by NHS England through the Genomics Unit, led by Sue, who will be giving a talk after this, and we've got a number of work packages, which some of them we will touch on today. Some of these are funded formal work packages, and others are bringing in other groups who have already got established programs of work. So all of this information is available on the website through the Northwest Genomic Medicine Service Alliance, and this is a partnership between the Northeast and Yorkshire GMSA and the one in the Northwest. And of course, in the Northeast, you've had a very strong reputation over a number of years, predominantly through the work of Anne Daly, who you'll see a little bit later, leading some really phenomenal pharmacogenetics programs. And so it's been great to have that partnership and obviously be here today. So some of the programs of work we won't focus on today, like our study, the progress study, but some of the things we will delve into in a little bit more detail, and I'll touch on that just in a second. But just to give you a sense of some of the highlights and some of the progress that we've made, that the study in primary care, the progress study that we've been initially leading in the Northwest with GP practices in Liverpool and in Manchester, have expanded up to Blackpool and Clitheroe. We're now national for that project, so we've got sites pretty much all around the country, which is great, and the work of Nicola and Eva and Amy, the team supporting us to get those sites open has been really great. We're now able, through the work of Scott and Vidya and Mike and others that have thought about how you move that information around the system, able to get those results appearing within GP records, within practices all around the country, and providing guidance around how those, what intervention should happen based on that information. So that's working really well, and I think in the next meeting we'll go into that in a little bit more detail. So we've got a number of other projects going on, sort of point of care testing, which you're aware of. We've been very interested in Manchester for a number of years, thinking about that around the context of neonatal hearing loss associated with gentamicin. We've got a national programme which is extending beyond England into Wales, Scotland and Northern Ireland, and that's working well, funded by NIHR, and we've been very keen to look through the Network of Excellence to see how we can raise funding from other organisations. And in that regard, since the last meeting, there's been a couple of successes. So Munir Pir Mohammed, who's here and you'll be aware of, has led a lot of pharmacogenetics initiatives across the country and internationally. Was awarded an Innovate UK CERSI award around regulation and innovation in pharmacogenomics, and there's a number of people from partners that are here today that are working with Munir around that programme of work. And then other funding stream from Innovate was an extension and expansion of our programme of work in Manchester called the Devote programme, where we're working with a number of smaller companies to develop either diagnostics or quality assurance materials. So today we wanted to pick out some things that have been a little bit different. We don't want these meetings just to be the same every time. We want different perspectives, different opportunities to hear about things. So we're delighted, I'll make an introduction in a second, to have a national perspective from Sue Hill. We then got a small panel discussion about sort of what we need to do to engage and involve public and patient views and make sure that's very central to what we're doing. And then we're delighted that Ron van Schaik is here from the Netherlands, who's been leading European programme of laboratory testing and is really at the forefront of how pharmacogenetics should be delivered. So learning from other experiences, really fantastic. And then in the afternoon, we've got some workshops. Some dates for your diary are that the next Network of Excellence event like this will be in Manchester on the 13th of November. I think we'll have a QR code or something that will pop up about that. If you, from today, have ideas about what you'd like to hear at that meeting, then do please let us know. We've already got some ideas ourselves, but we're very keen to hear of other things that you might like to know about. The European Society of Human Genetics runs a pharmacogenomics course. That's going to be on in a month's time. There's still availability if you want to register for that. QR code is there. It's in Slovenia. It's led by our colleague Vita Dolzan, and a number of colleagues from around Europe will be speaking at that. Then Munir, again, leads the UK Pharmacogenetics and Stratified Medicine Network. They've got a meeting at the Royal College of Physicians in London on the 18th of June. So you can click on the QR code in the middle, and that will take you to all the details about that. You can register and go to that. It's always an excellent meeting, which brings in a number of different perspectives. And then Ron is very much a leading member of the European Society of Pharmacogenetics and Personalised Therapies, or Therapeutics, I think. And Daly was the president of that society. He's now Nico Nimi. And they have their meeting in Rotterdam the 5th to the 8th of November. So get that in your diary, because it's always a really excellent meeting as well. So lots going on, lots of opportunities to engage around pharmacogenetics, irrespective of your starting point and your background. Right, now next we're going to move on to a different sort of discussion, and this is going to be led by our wonderful colleague Vivian Parry, who has been a leading voice in genomics over a number of years, but that engagement with the public, listening to the voice, sort of reflecting that back and amplifying it and understanding what it is that we can really do in partnership. So I'm absolutely delighted to invite Vivian to the stage to set the scene for the next session. Thank you.
Thank you so much. How lovely to be here. Now, as you know, I am a super enthusiast for genomics and always have been. But pharmacogenomics is the thing that I have been fixated on for many years. And it's funny, isn't it? I mean, genetics was my degree subject, and Sue was talking about slam dunks. I always thought about genetics as slam dunks. And over the years, I've realised that genetics isn't about slam dunks at all. It's very grey. It's not black and white at all. But with pharmacogenomics, it's a slam dunk. As far as the public are concerned and all the work that I've done with the public, it can be summed up in kind of just 3 words. Why wouldn't you? Why wouldn't you? So I think the work that we do with patients is incredibly important, not just about providing the impetus and the support that's visible to government in terms of funding, but also in terms of they will be the people who determine how we actually implement and deliver. And patients are the Trojan horse of genomics. They will make it happen. And actually, instead of patient push, you have, or health service push, you have patient pull. And I think in genomics, pharmacogenomics, that is incredibly important. Patients are the key to all of your futures because they are the ones who will make it happen. Even, all your efforts, it's patients that have the potential to really make it happen. So what we're going to do is we're going to have 4 talks, including one, I'm delighted to say, from a patient. And first up, we're going to hear from John McDermott of course, Centre for Excellence in Manchester and a clinical geneticist. So John, let's start with you.
Thank you very much. Oh, there we go. So I want to speak today about some work we've done looking at how we can understand stakeholder preferences for pharmacogenetic testing and a pharmacogenetic testing service. And this was funded by the NIHR as part of a fellowship from a few years ago. So first of all, we really need to establish what do we mean by a pharmacogenetic testing service. A pharmacogenetic testing service is not the laboratory test, nor is it that single interaction between a clinician and a patient, but actually it's the combination and the interaction between those 2 areas. And I've spoken about this before, how you can think about single gene testing, you can think about panel-based testing, and lots of different models of service delivery. And you can combine them in lots of different ways. And really, a pharmacogenetic testing service, as with many clinical services, has to be end-to-end. And there's lots of different components to that. How do you order the test as a healthcare professional? How is the test done? Are you doing single gene testing? Are you doing panel testing? And then how are those results returned? Do people have access to those results? Who has access to those results? And there are choices to be made along that pathway as you are designing a clinical service. And how you go about that will differ depending on your area of need and the health service which you are part of. The question is, how do we make decisions around how that happens? And traditionally, that's been people like us sat in a room just making those decisions. But actually, we know getting the input from patients and from healthcare professionals is absolutely critical. And we know that those different components, they don't sit in blissful isolation of each other. They interact with each other in very complex ways. In 2016, the Royal Academy of Engineering published a piece of work called Engineering Better Care, which looked at this systems-based approach to thinking about the design of healthcare. And people were at the core of that. Before you can do anything, you need to understand what your stakeholders, what your users need from the service that you are trying to design. And so defining the interactions and critically the preferences of our users and our stakeholders is fundamentally important. And our stakeholders make up the healthcare organisations, the laboratory testing services, the tech providers, but actually it's the interaction between your healthcare provider and your patients where you're going to drive action. You need to realise the intervention in that particular interaction. And so you can have the best laboratory test in the world, producing data with unparalleled accuracy and potentially even clinical utility. But unless you design a service that people can use and want to use, no one will use it and it will fail. So we aim to establish public and healthcare professionals for a pharmacogenetic testing service, and we're going to focus on the work we did around members of the public. And we worked with a team of excellent health economists to use tools around preference valuation. And there's lots of different tools that can be used. You can do revealed preferences, so you can look at what people do in the real world to understand what they want or what they need, or you can look at stated preferences. You can ask them. And there's a number of different ways that you can do this. And we used a tool called discrete choice experiments, which breaks down a particular service into attributes. And it's important to talk a little bit about what we mean by attributes and levels. And I'm going to do this through a tortured analogy of running shoes. When you make decisions in life, when you go to a shop and you're deciding which product to buy, you're not making decisions based on them as homogeneous entities. Rather, you're making trade-offs between the various attributes, and you do that subconsciously. So if you're picking a running shoe, you might make decisions based on the brand of that shoe, whether it has a carbon plate, the durability, the ankle support, and critically, the cost. And that awareness that actually different products have different attributes, you can use that within a survey-based design. And then if you ask people to make choices about which product, which service they would choose again and again, and you do that iteratively, through mathematical modelling, you can start to draw out the attributes and the levels that drive uptake. And that's what we did, not around running shoes, sadly, we did it around pharmacogenomics. So we conducted a discrete choice experiment, and it's a complex process to design and implement a piece of work like this, but you start with a choice question. We wanted to ask members of the public, if you had to choose one of these pharmacogenetic tests to help you guide your treatment, which would you choose? And you have to choose your attributes, and it's a bit of an art how you do that. We did that through engagement work with members of the public. We looked at the existing literature, and we chose 4 key areas: the type of test we were doing, data availability to the patient, whether that data was available in the future across the healthcare service, and the turnaround time of that particular test. We put all that into a survey, and we developed training material. And I want to show you just a very quick snippet of that training material to understand the choices
There are
we're
many
asking
ways
people
this
to make.
testing service can be developed, and the NHS are looking to understand the thoughts of patients and healthcare professionals before any plans are put into place. This survey will ask you to imagine you're a patient seeing your GP. They have offered a pharmacogenetic test to help choose the best medicine for you. You'll be presented with 2 alternative tests to choose from. Each test will have 4 features. You can use these to help make your decision. Let's look at these in more detail. You'll be asked to think about the type of sample you prefer to give: blood, saliva, or a cheek swab. You'll be presented with different ways you can access the test results. And, more broadly, whether the data is made available to the wider NHS to support future prescribing. Depending on how the data is stored by the NHS, the test results might just be used to help choose the best medicine for you at that particular moment in time, or they could be used to guide prescribing throughout your life. Finally, turnaround time is the time taken from requesting a test to the receipt of results. Some pharmacogenetic tests are very quick, others are slower. Thanks for listening. You'll now be given some more information on the survey before it begins.
Great. So patients were shown video like this, they had training material, and then they came to the survey itself. And this is the type of thing they saw. They were presented with pharmacogenetic test A, pharmacogenetic test B, the different attributes and levels within that, or they had an ability to opt out. But they were asked to make that choice. And if you were to present every theoretical possibility of that test against every theoretical possibility of that test, you'd be talking about over 6,500 different questions you'd be asking people. But using a mathematical design called de-efficient design, you could rationalize those into just 8 questions and maintain that same statistical robustness. We had 2 particular cohorts that we separated people into. We looked at either a patient presenting in pain and a patient presenting with low mood. And we wanted to do that to explore whether the acuity of the presentations might influence patients' decisions. And we aim to recruit at least 750 participants per scenario. And so we did that successfully across our scenarios. We had nearly 1,000 patients per scenario. And what we found, the first piece of work that we did, was to look to see whether there are any differences between our low mood scenario and our joint pain scenario, and we found no significant differences. So for the rest of the analysis, just bear in mind, we're looking at the total cohort. So the acuity of the presentation in this particular piece of work didn't seem to influence a patient's decision. This is what the data looks out coming out of a discrete choice experiment. It's incredibly dull, it's incredibly dry, but essentially the thing we're interested in is something called the coefficient. And I apologise to the health economists in the room, but broadly, you can think of it as if that number is bigger than 0, people want that particular level in their service, that feature. If it's below 0, they don't want it. So the first thing to say here is a constant of 4.85, which is for the overall test itself, suggests that people want pharmacogenetic testing broadly. But you can take those very boring numbers and present them graphically, thankfully. And so what you can see here is that if you use a base case service, which is essentially how we deliver reactive testing at the moment, where you do a blood test, data's not really available to the patient, not available in the future, and we chose a turnaround time of 20 days, you have an uptake of around 50% for that test. If you use an optimized service, where patients have access to their own data, where you're reusing that data over time and maybe use a non-invasive approach, that uptake goes well above 95%. And then we're able to do things called willingness to wait. So people are willing to wait longer for their results if you deliver a good service to them. And critically, what we found is that people will wait 10 days longer to get that result if they have access to their own data, ideally via an online portal, and if the data is reused over time, and people wanted non-invasive methods. But what we know is that the population is not a kind of homogeneous entity. There is huge heterogeneity within the population, and we undertook something called latent class analysis, which allows you to understand whether there's different preferences and different groups within the population. And what we found was that there were 4 core groups within the population as it broke down. And we found that around 4% of the population, no matter how good you made that service, they did not want genomic testing. They did not want pharmacogenomic testing. But the remaining 96, they were variably sensitive to how you designed that service. And class 1 were a group of around 30% of the population who really wanted that data reused in the population. And so if you said the data's not reused, they didn't want the service. If you said it is reused, they were more likely to take it up. The biggest predictor of whether patients chose to have pharmacogenetic testing was whether you gave them access to your data. And around 50% of the population, class 2, wanted access to the data. If you didn't give it them, they didn't want that test. So great, we've done a discrete choice experiment. Who cares? What are we actually going to do with that information? And we've taken the findings from this and we've already embedded it within our design of the phase 2 of the progress study. So in phase 1, we took blood samples, we did that in person, but actually in phase 2 we now have non-invasive sampling approaches that patients can do at home. We have an interoperable data solution, which Bill has already mentioned, with reuse of the data, and we're trying to make data available to patients, and we've now built that in to the study protocol based on this very clear feedback from our public stakeholders. And also, we've created a nice app. So if you want to have a play around developing your own pharmacogenetic service and see how good you can get it, then follow this QR code and you can have a play around, and that takes the raw data from our file, and yeah, you can see what you can do with that. So this has already been used by some health services who we work with around the world, who have found it really, really useful to see how those design decisions really do change how a service might be used. So I am not, as you can probably tell, a health economist. I am incredibly grateful to Catherine Payne, who's here today, and Stuart Wright, who's supported me throughout this programme. Both of these, so the work on the patient views has been published, as have the work on healthcare professionals, which we didn't touch on today, and you can follow them via that QR code. But I look forward to the discussion. Thank you very much.
So much. I just have to ask you though, what is, I wrote it down, a hedonic pricing method? Is that about very fancy, that you're, with running shoes, you're so kind of dazzled by the cost of the shoes that you just buy?
Address questions like that to Catherine Payne, who's
Quickly, what's a hedonic pricing method? You see, they make it up as they go along, don't they? Tell you what. We're intrigued. We want to know about the pricing method because it sounds good. It's the kind of the Prada of the health economics. Right. Okay. Let's now move on to Dr. Emma McGovern. Emma is a MRC clinician scientist and a lecturer in clinical pharmacology at QMUL. And I've been delighted that I've been able to work with her to do a survey on attitudes to pharmacogenomics. And could I just say, if there's anybody in the house, she has come here even though she might suddenly have to dash around. She's come with her records.
Totally no time in suitcase. All right, thanks so much, Viv, and lovely to see you all here today. It's wonderful about pharmacogenomics, that it's such a fantastic community that works so well together, and that's really a real pleasure for those of us that get to work in this team. So to follow on the wonderful talks we've heard so far about the work that's been done within this fantastic network to include patients and the public voice in every step of what we do within pharmacogenomics and designing a fit-for-purpose service in the NHS. We all know about the promises of personalised prescribing in terms of safety, efficacy. We can have a good debate with the health psychologists about adherence, compliance, whatever you want to call it, which none of us can really answer so far. But there's lots of benefits. But to get there, really we have to go from evidence-based and controlled settings to practice. And when we talk about that step, actually I think the whole set of concerns become really, really different and hard to understand without talking to those who are actually the ones involved, which is our patients and the public. So what we wanted to do was reach out at scale to a representative sample of UK adults. And we had the really great fortune, thanks to funding from the NHS England network and from Genomics England via Vivian's team and the public engagement panel, to work with the National Centre for Social Science. They go by NatCen. So if you've ever heard of sort of any of the surveys in BBC that I presented as to sort of what the public thinks about the monarchy or how much TV people watch or something like that, it's normally NatCen and their opinion panel, because they've done a really brilliant job of getting cross-sectional views from a representative version of the population of UK adults across the 4 nations and across a huge number of really staggering number of demographics. So we worked with them to collect some data around people's opinion of pharmacogenomics last summer, and we had the good success to have a 58% response rate and collect over 2,700 responses. So how did we design these questions? So we had a really wonderful collaboration from many of these people who are here today, working with the NHS England Network of Excellence that's hosting this fantastic event, all of those within Bill's team, the Genomics England panel led by Viv Parry, health psychologists, so I saw Alison here today, maybe John as well from King's, and then the NatCen team are really experts in fine-honing these questions and formats so that you're asking sort of unbiased, well-balanced questions and making them accessible to people, which is really helpful. So they got opinions reaching out to 4,700 people within their opinion panels, and we got that 58% response rate, leading us to just under 3,000 responses, to which we applied weighting so that we can say fairly that these views are representative of a cross-section of the UK adult population. And this gives us a basis to move forward in terms of fit-for-service pharmacogenomics and public opinion. So what do people think? Well, first of all, people really understand variability in medication response. And I think lots of us have had these conversations, so maybe that's intuitive. But it's nice to see. The other thing to say is that the majority of people do feel that they've had experience with either medicine ineffectiveness or an adverse drug reaction. But if you start asking, well, what do you think the role of DNA is in that? People are substantially less sure. About half of people will say, oh, yeah, maybe DNA has something to do with it. And about half will just really say, I don't know. So why would people want to undertake a pharmacogenomics test? I think this was really quite informative. I think bottom line message here is that nearly 9 in 10 people, for at least one of these reasons, would choose to take a pharmacogenomics test. And if you have them prioritize their motivation, then the strongest factor is really effectiveness of their medicine. People really want that medicine to work for them. And that's followed by not wanting to have a side effect, not wanting to have a bad reaction, but actually is secondary. And the health psychologists could have told us this, and in fact they did tell us this. They said, you doctors, you're all fixated on side effects, but actually patients are much more centered on effectiveness. I think that was Alison who's here today, and she was spot on. So they already knew this, but it's nice to see. So the question of medication adherence is really interesting. I think we heard from Lucy at one of the last meetings about the conflicting evidence in the literature around the possibility for personalised prescribing using genetic variants to impact on adherence, which those of us who prescribe know is a real worry. A medicine doesn't do anything for someone if they don't take it. And that's about 50% non-adherence, for example, in the realm of hypertension. So does this hold an answer potentially? And obviously one aspect is people's opinion, because they may do something different from what they say. But nearly 70% of people did feel their adherence would increase if they knew that a medicine had been personalized using their genetic information. Now, how do people feel about incorporation of such a service within the NHS? And granted, this is a time when, of course, people are feeling quite worried about strain on the NHS. So I think it's really quite striking that 85% of UK adults felt that pharmacogenomics should be offered to that highest risk population who have lots of medical morbidities and are taking multiple medicines. Now, slightly less strong opinions, but still over half of people at 65% thinking that actually it would be suitable for the NHS to offer this service to everyone. Now, we didn't ask people about prioritising economic sort of options and opportunity costs, so caveat there, but still a resounding support for incorporation within our national health system. Following on from what we've just heard from John, and Viv and her team, I think, will speak to this as well, but 91% of people wanted access to their own pharmacogenomic results. And I think across the board, we've seen that people feel really strongly about their ownership of their data and gating that themselves and holding that themselves. And that's really important takeaway message, I think, for what we can do. Now, I think it's really important also to ask people what their concerns may be, what might be worries, what might we need to put in place to protect this data if there's anything that people are worried could go wrong. So first, a quite simple question, and we saw that a pretty good percentage, actually, 64% were not at all worried about having a pharmacogenomic test, and a quarter just a little bit. So only 12% were actually even substantially worried potentially about this, but that was quite a simple question. So then we tried something else. We said, what are your worries across an array of ways that data could be used from pharmacogenomics? And what are your concerns as they would relate to general medical data? So a scan or a blood test in terms of identifying who you are, identifying what ancestry group you come from, potential requests from police to access that data, family structure. And then we asked with regard to pharmacogenomics. And the thing to note about these is that they're superimposable almost. People felt almost exactly the same way in terms of concerns about data in these areas across groups. Now, even though these distributions look almost the same, there are 3 areas where there were 1 to 2 to 3% more concern. And those were around things which are, I think, quite valid concerns if we do population-level genetic testing, let's say, not an individual genetic testing or one person in, 1,000 or something. People were a little more worried about ancestry being worked out, a little bit worried about family structure being worked out, so a little bit more concerned about identification of population and family structure, and a little bit worried about potential police requests for this data. But other than that, distribution totally equal, and actually people were more concerned about non-pharmacogenomic data for the other categories. Now, this thing about data sharing and what that means and what people are worried about, we've seen across the board in studies that people are pretty happy for pharmacogenomics to be shared across healthcare settings, to most extent with researchers, definitely with regulators, people feel quite confident. But the takeaway here is that only 10% of people were comfortable with this data being shared with private commercial entities. And that is really important, because if that's the starting point, then actually probably we need something prospectively in there that means people have control over that aspect, or we could end up with 90% quite unhappy people. So quite an important take-home message there. Now, informed consent has been an interesting topic around pharmacogenomics. This is not diagnostic genetic testing. We're using it to optimize medicines use. Again, if we do it one patient, one doctor, there's no other data there. It's only on a population level that it would ever be different from kidney function tests or liver function tests. But how do we manage that? What do people need to know? So right now, there's no minimum sort of criteria applied. So we asked how people felt about 4 basic things. Did they need to be told this was genetic testing? Did they need to be told that the purpose was to make medicines safer and more effective? And did they need to be told that actually, even if their medicines were personalized, they could still have a side effect, or they could still have a medicine that didn't work well for them? And actually, people felt pretty importantly that all of those were very important. or at least fairly important. So I think they've given us a bit of a minimum criteria for things that actually the representative public of our country think do need to be included in a discussion. Now, we wanted to ask people about pharmacovigilance because an important aspect of personalized prescribing is how we interface with genetic signals underlying adverse drug reactions, and then how we can build that into a holistic system where we're doing clinical pharmacogenomics. So we started out with some awareness questions. So only about a quarter of the population were aware of yellow card reporting, which is our national pharmacovigilance system reporting for adverse drug reactions. But of those people who were, the vast majority, 88%, did know that anyone can make a report. So patients, carers, the public, that it's not just healthcare professionals that can file a report. But really critically, that was an underpinning for this question, which is, do people want pharmacogenomic information included in pharmacovigilance reporting? In an ideal world, right, we do this clinically. We include potentially some more variants that can be useful to identify genomic underpinning of new adverse drug reactions, which is the point of the pilot project, the Yellow Card Biobank at the moment. And then when you send an adverse drug reaction, it's all seamless, right? Your medicines are in an NHS app, your genetics are in an NHS app, you have a bad reaction, goes to the MHRA along with all of that. And there was resounding support for that. So 70% of people wanted to be able to include that data in a report for adverse drug reaction. And there was more support in that for people who already knew about yellow card reporting in the MHRA. So that means actually perhaps if people were more aware of pharmacovigilance systems, there would be even more support for that. So overall, what did we get from this survey? We got an understanding that people really deeply understand variability in medicine response, that there's a lot of support for pharmacogenomic testing, particularly in those that are highest at risk, that people really probably will want to take pharmacogenomic tests up on scale, and that there's not substantially greater concerns actually across the board, but there are some particular areas that we should probably pay attention to. And I think one of those is patient gating of access to information for data sharing, particularly around private financial entities. And that's something that's come up again and again and again, and I think we should probably heed that. The other thing is concerns about identification of population, family level structure, and potential police requests. If we start doing pharmacogenomic panels at scale for an entire population, it's hard to believe that at some point forensics wouldn't have an interest in that. And if it's already something people are a bit concerned about, do we need some sort of a policy firewall there? I think these are questions that probably should be asked quite early. Lastly, I didn't show this graph, but there was a lack of available patient information. So over 95% of people had never heard of anywhere that they could get any of this information. So that's really important. We need the funds and the proper dedication to make these patient resources. And they've given us a minimum criteria to include for informed consent. Lastly, there's a lot of support for inclusion of pharmacogenomics and pharmacovigilance. So I just want to say a huge thank you to everyone who participated. So all the authors in the study, many of whom are here today. So we had the Network of Excellence team, the Health Psychology team, the NatSen, Viv Perry and her team, and the funders who made this work possible, which are the NHS England team and Genomics England for their contributions. And really the point is to get this right for the patients. So thank you very much.
Things that we take away from that is a definitive study. Enough already about attitude. Enough already. It's now that we move to implementation, because this is a really big study, lots of information, and we're going to discuss it a bit more in our session in a moment. So thank you very much. Now let's move to Dr. Vidya Sharma, Clinical Innovation Lead at the University of Manchester. Please.
Thank you. Thank you, Viv. Good morning, everyone. It's lovely to be here and great to see many familiar and lots of new faces as well. We hadn't planned this, but it appears that our presentations are following each other really, really nicely. I'm going to talk not about anything controversial, but those of you that know me do like, I like to challenge myself and challenge everybody that I speak to about the ways we think and the ways we work. And following on from what Viv just said, when I think about PPIE, particularly in the context of pharmacogenomics and personalized prescribing, one of the things that I've realized is that we know a lot. We know there is lots of evidence out there about support for pharmacogenomics, People understand it, people get it. I loved your 3 words, Viv, why wouldn't you? And I think that's something that we need to be aware of. Do we need to be doing more PPIE? Or do we need to be thinking beyond PPIE? This is just a really quick search of all the types of research that's out there, both looking at public preferences as well as healthcare professional preferences around pharmacogenomics. So we know that there is strong support. We have a good understanding of what are effective service models, as John's described. What are the attributes of a particular service that would drive uptake? That could be the method of testing. That could be the way the data is used. It could be around the way the data is shared. And we know that at a large scale. So I really want us to try to think about what happens in other industries when people have got a product or a service that there is a demand for. How do they move from understanding what people's preferences are to implementation? How do they move from an idea or a concept to product and services that people use on a regular basis? And the challenge that I want to pose to ourselves is around this concept that if we want to move into a world where we are more thinking about products and services, we need to move beyond PPIE. And PPIE is often extractive, so it is a kind of a one-way conversation. We're trying to get something from the people that we are engaging with, rather than collaborative, where we're working together to come up with solutions. Patients are involved, but they are not necessarily embedded within our projects. We engage with them at certain time points, the start, a quarter of the way through, 3/4 of the way through, and perhaps at the end. Often we don't go back at the end and give them feedback of how we've incorporated their suggestions throughout the course of the project, even though we often do. That is something that I often hear from patients and public members that I've involved in projects. They say, this was great, but whatever happened to that project? So in order to move towards a more, I suppose, contemporary mindset, one of the things that I often reflect about is to have a more of a user-centered design approach. And I've talked about user-centered design often, and you may have heard me talk about that before, but that's really about changing the way we think about engagement. And that's about it being more ongoing, about building trust and feedback, that we will come back to you to tell you what we've changed based on what you've told us, and a real focus on application and usability. So rather than it being theoretical, rather than we take these ideas and this feedback from our engagement work, we actually go and apply that, as John has described, as we've done during the progress study, where we've taken some of those findings of the discrete choice experiment and then gone and implemented changes, which then people can see. And in theory, if of course the theory follows the practice, that is going to drive uptake. So it's not just beneficial for people in the public that we engage with that we should be doing this, it's beneficial for us. That's the point that we're doing PPIE, is because we want to deliver better services. And the phrase that often is used to encompass that is this idea of moving away from designing for users to designing with users. And I think this is a general shift in healthcare as healthcare becomes more user-focused, as we increasingly do more PPI, and we start to embrace the fact that we need to be collaborative and we need to think about what it is that people want as we want to drive better health outcomes. And that's really, really important. So this is just one of the ways that we could reframe how we think about PPIE. One of the terms that I heard someone mention at a user experience conference was that advocate for your users at all times. As opposed to engaging with them at different time points, we should at all times be thinking, is this useful? Whether it's that's for the patient or whether that's for the healthcare professional. And John said that beautifully in his talk as well. If it's not useful, it will not be used. The reason we all use our smartphones or use various tools or a piece of technology regularly is because they are useful, and they are useful and they're usable. And that is the type of mindset that we, I think, would benefit from adopting, not just in genomics and pharmacogenomics, but in healthcare generally. It's something that I don't see us doing well enough. So how do you do that in practice? And I've got a list of some practical points in a moment, but first, there needs to be a plan, there needs to be a strategy of how we move from more segmented, isolated PPIE approach to perhaps a more user-centered, user advocacy approach. And that's firstly to think about resources and budgeting. So budgeting for design, not just comms and engagement, not just individual sections of engagement. have that space for iteration, as John has highlighted. So when you do get feedback, let's go and implement that feedback. Let that not just be something that we've gathered and we've written in a report. Let's go and apply it so we can see the impact of that in the real world. Patient involvement that's paid, ongoing, and bidirectional. This is something that I do not think we always do. We often pay our participants. That's fantastic. We don't often maintain a relationship with them, whether that's a postal relationship or a digital relationship. It isn't always bidirectional. We go out to them to say, hey, can you come and do a workshop and we'll ask you a bunch of questions? Rarely do we have a way for them to access us, to say, hey, actually, I saw something on the news that I think might be relevant. Can I tell you about it? And governance and leadership that values not just patient involvement and engagement, but usability and adoption, which are the steps where actually impact takes place. I think one of the examples where I've seen this happen well is the partisan panel at Genomics England, which Viv has led for several years, where some of these elements are certainly part of the way that is set up. And this is one of the quotes that I really quite like when people often think about design or they think about how something looks, and that is really what the job of design is. But it isn't. Design isn't about how something looks, it's about how something works. I don't know if anybody knows who this quote is by. No? No takers? It's Steve Jobs, so the founder of Apple. And I think that's a really important message and a really, really important way to think. And this is certainly something that I have adopted as I try to work in innovation. Okay, so for the last minute or so, let's talk about how do we do this in practice then. So how do we move beyond PPIE? So some practical suggestions, and very happy for people to give me feedback on any of these, right? These are some of my ideas and learnings. I might be completely wrong and you might completely disagree. I hope you do. That's the whole point of me presenting this. But moving towards this more co-design rather than consultative relationship, I think is a first place to start, and that's what we did during the Progress trial. So we worked together with primary care practitioners, both GPs and pharmacists. We went out to their clinics, we had virtual meetings with them, and we talked them through, we want to do pharmacogenomics, we want to present this information to you, what would that look like? And that is where we started. We didn't start with the technology, we didn't start with the data, we started with the users. And that allowed us to understand that, gosh, this is the only way this is going to work is if this is part of their existing clinical systems, which now seems very obvious, but you've not uncovered that unless you go and do that work. If it's part of their existing clinical systems and if it's part of their workflows. And that's what was the impetus for Progress RX and all the digital strategy and all the data and everything that we've developed subsequently. We started with the users and we worked together with them to design that. We brought in design skills within the team, whether that was through external contracting or actually bringing in teams from within the university. And we worked with service designers, we've worked with user experience designers, user researchers, a whole group of not healthcare professionals, a whole group of professionals working in healthcare that are not doctors, nurses, etc., but who bring really, really valuable additional skills. We design artifacts to drive conversations. So we draw pictures, we make prototypes, we design screens of what might this actually look like. And one of the common phrases that I really liked is, you will all have heard of a picture is worth 1,000 words, a prototype is worth 1,000 meetings. And that is something that is really, really true. So we, by presenting something visual to people, allowing them to click through something, allowing them to have that experience, you get such rich feedback, a lot more than you can just have from a conversation. We've tried to create patients and clinical advocates. So when there are people that are clearly early adopters, enthusiasts, we've tried to maintain a relationship with them. We've tried to continue to engage them where we can. And I think it's part of that. It's fantastic to have Mark here today, who's going to speak after me, as a patient representative, someone who is part of a community or part of a group that from within can say, this is something that is beneficial, or this is good about it, this is bad about it. That allows the rest of the community to come along with it. And this final piece around building feedback into infrastructure. So I think one of the things that we are trying to do more of is be more accessible to our Progress participants, for them to be able to get back in touch with us at different time points to ask questions. So we have that ongoing bi-directional relationship with them. And I think that's something that we can maybe do more easily, whether that's email addresses, whether that's a phone number. And not many people will get in touch, but allowing that accessibility makes us look a lot more compassionate and a lot more open. Fantastic. I'm going to stop there. Hopefully that was useful and a little bit thought-provoking, and I look forward to the discussion. Thank you.
So, and now, where is he? Mark Joseph Rapper, we're delighted to have you with us. Patient, you've been working with this team, so do...
Good morning. It's a pleasure to be here, and I want to thank the and the rest of the team for having me here and for inviting me to be part of the workshops which we organized. In the... Ooh, there we go, shall I? There we go. What I want to go through is how I got involved in the study, what happened when I got the results, and some thoughts which I had after participating. Because most of the thinking process as a patient, the thinking which I've done was after the effect. It wasn't during the consultation which I had with my clinician. So I enrolled in the trial in November 2023. It was through my GP, and my story, I think, is very probably similar to many people. Is previously I was on SSRIs and did really well, but I gained a lovely whopping 20 kilos, which I worked really hard to lose. A few months later, I needed to go back on SSRIs. I knew that I should have been on them for a few weeks already. So for me, the sense of urgency was ever present. But also there was a great hesitancy in that I don't want to gain that weight again. So my very lovely GP at the time said, well, there is this trial and we will find out. And I remember interrupting her and I said, when would I get my results? It didn't matter to me as a patient at that point how the tests will be done, who is going to be affected. I just wanted my results, if possible within the next hour. It wasn't, but it wasn't very far either. So the process, she explained what pharmacogenomics is and how it will work. I will get a testing kit from the reception and someone will call me to take my consent over the phone and explain the entire process. So the consultation wasn't longer than usual. Yes, there was a bit of computer hiccups into how to navigate the system, how we get you the right nurse to give you the right kit. But went home, read the information sheet, lots of words, but very understandable. I did think a video would be really good in this instance. And I remember Googling online and I finding information about the progress study, but at the time, I couldn't find a video. There are many videos online now, so if you're interested, there are many, many videos, which are really great. And there was the testing kit. It was quite a straightforward test. You just spit into a tube, and then you had the option to either post it or you drop it off at the surgery. That was very convenient. I lived close to the surgery, but for someone else, having the option of just dropping it off into the post, that is brilliant, because you don't have to go back to the surgery. And on the consent process, we had a lovely chat over the phone. They explained what was expected of me, how it will work out, when should I expect the results. But again, my focus was also, when will I get the results? Can I get this within the next 5 days? And throughout, I should have mentioned that that was 31st October when I actually enrolled on the study. And it's important to remember that date. And I remember asking the person on the phone, so when will I get the results? And they said, in 2-3 weeks, you will get the results. But all along, and this is what I think made me even more go on the trial, is that the GP said, so these are the options. So we can either go on sertraline or we can wait for the results to come out. I was given the option. My views, my concerns about the anxieties about delaying another week or 2 were appeased a bit knowing that I've had that option. And they said, you can either start these now and we evaluate when we get the results, or you can wait. So it was all about building the trust with my clinician, and I decided to wait. Later on, I was involved in the workshops with Vidya and the other team, and it was really interesting because there were 2 separate workshops, not 1, 2. And why wasn't important it was 2? Because we focused on different parts of the study. So the before and the after. Because for each of us, we may muddle them both together, but separately they are very important. So how did I find out I got the results? My lovely GP sent me a message. Your results are in. And I'm like, brilliant. So what do we do now? We had already organized a follow-up consultation. So my GP in the first appointment said, you know what, let's schedule an appointment for the next few days. And by that point, if you have the results, we'll go with that results. If not, we'll go on the sertraline on the first line. And again, this is giving me the assurance that there are options available, that I'm not being left to decide by myself, but it's a shared decision which we are making together. And then I received a text message, results are available, brilliant. Go to the consultation, and I was prescribed a drug which had the least adverse effects, which was going to work better for me than any other drugs. And I was sent away with the prescription. Brilliant, fantastic. And I've pressed the wrong button, brilliant. That took 9 days. So that took merely 9 days, 31st October, 13th November, it was my birthday, that's why I remember. It took just 9 days for this entire process, okay? And again, I want to emphasize my importance that it wasn't how this is gonna work out, it's when am I gonna get my results. Went home, and so what do I do now? So I've got this information, I've got this knowledge, but I want to read more about it. What do I do? What adverse effects was she actually talking about? I don't actually know. I just said yes because I wanted to get better. I want to get better faster, but also I can't expect my clinician within 6 to 8 minutes to explain what that actually means. So if I were sent away with some information, I could do that myself. And yes, we spoke about adverse events, the effects, but which ones were they? And for example, I've discussed this with a friend of mine, and we spoke about the weight gain and the SSRIs. And they said, well, actually, if someone said, I take SSRIs and I gain 5 kilos, which I've been trying to gain for the last 5 years, I'd be very happy. I wouldn't be happy with that. So there are adverse events which for some patients, they're happy to tolerate. Others are not. And I think that is why it is important to have an explanation of what adverse events are and how they affect each individual. The GP's concerns about the adverse events would be different than mine. And that is why the shared discussion is made. But is there enough time to have that discussion? Probably not. But there are ways we can manage that. If I had the access to my results online, if I could access, and I have this nice chart of telling me these are the drugs and these are the effects which you may or may not have, and this is the level of severity, then I could go to ChatGPT, I could go on the internet and start Googling. But I'm Googling after the fact that I have some information already. If I were to Google any of the SSRIs, you'll have the same list of side effects, some worse than others, but it's not the personalized information. Whereas if I have a list of the drugs and I have a list of the severity, then that might lead me to make a better informed decision about what treatments I want to get on. So some would say that having access to the results will cause patients more anxiety. In my case, because I can only speak from my experience, that wasn't the case. It was actually the other way around, that I know that there is some information somewhere about me, but which could help me make future decisions, but it's not available to me. And if it's not available to me, what is the point of doing the test? And if this were part of routine healthcare, What if the test is immediately available to everyone? And that is immediately incorporated within something like the NHS app or any other way I could be a better advocate for my health. And this is where I wanted to get to. So I moved GPs, as most of us probably do. You move from place to place. I live in Manchester. Wherever your catchment is, you have a different GP. And I wanted to change my SSRIs. We tried to find the data. We couldn't find it on the system. So what happened then is my decision to go on the next SSRIs wasn't an informed decision. We're so much concerned about the informed consent at the beginning of the process that we forget sometimes that later decisions are affected by information which the NHS may hold, which the GP practice may hold, but I don't hold. If I were to move countries, if I were to happen to be abroad and I need to go on statins or something or another, I don't have that data. And why shouldn't I have that data? If it is about me and it is, at the end of the day, helping me and saving costs, then why shouldn't it be the case? There is also a question about the language which we're using. I want to make 2 points about the language. So we speak about adverse events, which can trigger some people. I'm like, okay, this is going to be a bad thing. This is going to, all the negative side effects. But what if we reframe the language into, let's look at what treatment is better for you, rather than the least effective. Let's change the negative to a positive. Which treatment is better, is best for you? Because that gives the individual less anxieties and less likely to go online and use those same words. Because those same words will trigger lists of probably you're gonna die. And we hear a lot about the importance of, if you look online and you read about the benefits of personalized medicine, one of the key things which comes at the very top usually is saving the NHS money. It's great, important. We all want to save the NHS money. But usually the patient empowerment comes towards the end. But if we are to reframe that language and starting from the point of, we've got this brilliant tool, and this brilliant tool will empower the patient, will give you the information to make better decisions about yourself and about your healthcare. And by the way, this will save the NHS some money. When I hear about saving the NHS money, the first thing I think about is not better healthcare, but cost cutting. If I want to save money, I have to stop spending money elsewhere, which is not what I as a patient feel confident to hear. So if we rephrase the language into it being a more positive, what is the better treatment for you? And here the NHS, this hospital, this trust, is looking at this study to make you feel empowered to make these decisions, not just today, but you can carry these decisions with you in your pocket, and wherever you go, you can advocate for your own healthcare. And the last slide is, there are one of the workshops, there were concerns about how are GPs going to do this within the 6 or 8 minutes framework. We simply do not have the time to go through all this. I get it. And that is why, going back, sending the patients with information makes things much easier. Also, the patient is not thinking the way you're thinking. We generally don't care about the letters or the numbers or the graphs. We can't understand them. All I want to hear is about what treatment is going to make me feel better, which information I can understand, and where can I find it. And we already do that in that GPs send you the information via text, they send you links to read at home, and if you have someone who wants to understand the science, then you link them to the study if you want to. So whilst there are anxieties about the time not being long enough, it's about using the resources wisely. We don't need to go into great detail what this test is going to do. For me, it is sufficient to hear, look, there are these options, but we can find out which is the better one by doing this test. You will get this test within 9 working days. Are you willing to wait? If not, we can start on this treatment. And if you're willing to wait, then let's re-adjourn in 2 weeks. And in those 2 weeks, you don't have to have an in-person consultation because you've already done that. You've sent the patient with information at home. So then it can just be a telephone conversation. Look, the results are in. These are the medications which are better for you. What do you want to go ahead with? And the last slide which I have, what is the aim around all this? When I think about it from outside is we want better treatment and we want to go less to the GPs. Why would you want to go to GP if you can do this in any other way? And we want to save money for ourselves. We're still paying for the prescription, however low the cost is. But for some people, $9.90 a month on medication which is not working for them is quite high. And we want to save our health. Why would I spend 2-3 months having adverse effects when I know I can have better health without those side effects? And we want to save the NHS. So what do we need? We need access, and we need accessibility. So the language which we are using, where you pick up the tests, where you drop off the tests. The language which we are using, reframing the text into a patient-centered, and then the cost comes later. Also that we rephrase the adverse effects into which medication is better for you. And reassurance. Healthcare clinicians have a very difficult job in reassuring people, especially anxious young people who want to go on SSRIs now and they need to work by this evening because I want to be feeling like a fresh person by tomorrow morning. So giving that reassurance is very hard, it's very difficult, but it is manageable. If we do all that, what we would get is shared decision making because we are empowering people with the right language and reassuring them and giving them access to information. We are building trust in clinicians and technology. Some of the hesitancy which people may have is because they don't trust clinicians. And trust in technology. So who owns the data, for example, may be a bigger question, but it may only interest a small demographic of people. We will get better outcome, and we would save the NHS money, and we would save the NHS. Thank you very much.
That was fab. Do take a seat. That was terrific, and you are so singing my song. And I take away from that, again, in a short, pithy phrase in my tabloid journalist way, is don't make a mountain out of a molehill, folks. You know, simple works better. And if you over-engineer things and make it too complicated, then actually you'll drive people away. Quickly, can we have our panel back? The other Emma, how long can I munch of coffee time?
Sort of now-ish.
Yes.
We can defer because
Yes.
this is good.
Yes. All right. Thank goodness he said that.
Have less time having coffee, if that's all right.
Am I allowed? That wasn't a very enthusiastic. But, okay. So, oh, God, there are so many questions okay, John, are you worried that if we overhype pharmacogenomics, which incidentally we cannot call pharmacogenomics to the general public, they can't say it, but if we overhype it, then what we'll get is we'll get people believing that it's all about, adverse effects are all about genomics, and they don't have to read the label.
Yeah, absolutely. I think that pharmacogenomics has major promise to be able to improve health outcomes for individuals and for health systems, but it is not independently a silver bullet. And I think it's about explaining that this is predictive, but it's not perfectly predictive. And actually, it's about how you embed that with other biomarkers. So if a patient's on lots of medicines, then actually that might interact with your pharmacogenomic results. And it's about getting patients to take their medicines as well. So pharmacogenomics is a tool. It's a really useful tool, but it cannot be the only tool in our armory. And what we need to do is to develop more sophisticated ways of implementing this within a service?
Yeah, so the fact that when I went out the night I got my final results and I'd had antihistamines because I had a big bee sting that day, the fact that I drank pina coladas all night was all the reason for my adverse effects and not at all anything else. Emma, how far, we've said boldly that we think that's enough already, that is the definitive piece of work on attitude. What do we need to do next in terms of attitude? Is it about now implementation and what people think about implementation and how to do it?
I think taking people's opinion and doing what they've said, essentially. So I think we've heard really nicely from you as well, the need to have really accessible patient information that's proportionate, that it filters down the huge amount of information out there in a way that's reasonable, and that's really important. So I think we need that patient information, and I think also we need to listen to people's concerns. I think we've heard across the board concerns about scaled data and this level ending up being shared with private sort of financially driven entities. And potentially there's some aspect of that where, patient consultations with policy need to create some policies, for example, firewalls, gating of information, which is led by patients that's specific to that type of information, that actually is unique. It doesn't apply to your liver function test or your kidney function test, and it doesn't apply to rare disease testing and genetics. So I think we really need to just follow the patient and essentially do what they've told us.
Mm. Do any of you know Partha Carr in here? So Partha Carr is a clinical lead for type 1 diabetes in the NHS. And he decided to take on improving access to closed-loop systems for type 1 diabetics. And only 3% had them at the beginning of his reign, and it was 97% by the end. And the reason, if you go to him and say, it must have been about money, did he discover a gold mine under NHS England, under Skipton House? And he said it wasn't about that at all. What it was about was actually patient advocacy, because his reduction of the NHS was 30% of people in the NHS are early adopters, 30% will just put their heads down and do things, and then finally there are 30% who think, I will only do what I want to do and don't you dare bloody tell me what to do. But actually, it was patients that made the difference, because they marched along and they said, everybody else is getting this, why aren't I? And that patient advocacy became a huge force. And you mentioned it, Vid, and I wanted to ask Mark what you thought about patients being advocates and champions for pharmacogenomics.
I think it is possible, and I think the fact that I am here as well is already an indication that we want to get patients on board. I think how can patients be champions for pharmacogenomics is by making the information widely available, but it's also word of mouth.
Yes.
So it's when you have people who are on statins who come together, or if I'm on SSRIs, I was telling my friends, like, I've done this study, and this is why I know that this drug is great for me, and this is not so great for me. So that is how you would build the advocacy. And it's more a bottom-top approach rather than going to publishing information on the website, for example. We were thinking yesterday, like, what would work is going on to the Good Morning show, for example. A 5-10 minute segment. This is happening, and this is what you could actually benefit from it, and then how you would do it.
Yeah, but also it's having something on your phone. You say having the data yourself. So if you have an app on your phone, having an app on your phone, and you can show your friend in the pub and say, oh, look, I did this, have you seen? I mean, we're always saying to each other, have you seen this app, or why don't you get this? And we could do the same for pharmacogenomics, and it be an organic movement for change, which comes from patients.
And I think younger people, there is, obviously my experience is of a younger person, younger white person. So there are other demographics which are not even in the room probably, who might have a different experience. But the experience of a younger person is important because I think it drives the change. And I think we are more open about our healthcare, about the way we feel and the way we think. So I think having that study and that option available and the information available to younger people can drive change maybe even faster within some areas.
John?
We definitely know there is a pent-up patient demand. And so last year, after NICE made the recommendation that all patients who've had a stroke or TIA should have CYP2C19 genotyping, it was round BBC News, a number of other news organisations. We had a large number of calls over the next month from GPs and from patients getting in touch with us asking, well, can we have testing for this? And people want access to this testing because it's a simple message that actually we can do a test to determine how you're going to respond to your medicine.
Now, the worst thing that could happen with pharmacogenomics is that, I've got my stuff, I've got my app, I go to a GP and I say, cop a load of this, as you do to your GP, and or pharmacist, and the GP just blanks you and says, don't know anything about this. And also, we've kind of created an environment in genetics where there are all sorts of commercial tests, which are rubbish. And people go into the GP. So GPs have been conditioned, I think, not to accept the person that comes in and says, look at this genetic testing. So how do we persuade GPs, how do patients help persuade GPs that this is genuine, proper stuff and not some nonsense off the internet?
I think there's two elements to that. So we work a lot with GPs, and it's great to see some GPs in the room even here today. So the fact that we're trying to engage that community actively, I think is the first step. But I think there's two practical things that we've heard are important. So I think firstly, if it is an independent app or it is a separate place where this data is being made available because of a lack of integration, etc., is there some kind of accreditation, NHS approval
A kind
system?
of an NHS wrapper.
That's right.
Yeah.
So does it have a stamp on it? I think that drives trust significantly. The other thing is that it needs to be really easy. So if you are wanting to give this information to your GP, outside of the existing NHS infrastructure, does your app have a button to say, share with GP, what's your email address, GP, click, and then it goes to the GP in their inbox and they have access to your information in a GP-friendly way, not in a genetics-friendly way, because just as much as the language we're talking about communicating with patients, primary care colleagues are the same. They are not genetic experts, so the language that we use there, again, needs to follow much closer to what we use when we speak to patients, and that's where that information is available. And really simple features, so people don't want long reports of like all the medicines that someone could, like Ron's picture with, that's not what GPs want. What the GPs want,
Traffic lights. This.
They want.
Don't.
They want to. What they want
think about it.
They want a search bar.
Okay.
They want a search bar. They want a Google. Yes. They want sertraline, green, red, delete, tricyclic antidepressant, enter. That's what they want.
Yeah.
So it's about designing things that are really usable, that are similar to how we use other services, and do not give people information overload.
And one thing we haven't discussed today is pharmacists. How many pharmacists have we got in the audience? You see, I think you're super important in all of this. I want you to be super important in all of this because, why can't a patient show their data to a pharmacist and say, what do you think? And pharmacists now have the ability to change medicines, don't they, without going back to the GP, within the same class? Oh, no. Okay. All right, then. I'll go quietly. I'm going to take one or... John.
Vivian, I'd like to direct a question to Emma. I'm John Byrne, Professor of Clinical Genetics, and I chair the Research and Innovation team. And Emma Groves is one of the members of that team, along with Steve, who's behind me. And she asked the question, which I've been wrestling with. Why don't we just test the mothers instead of testing the babies for the gentamicin sensitivity? So, Emma, you had a pharmacogenomic test called your blood groups. Okay, you were blood grouped. You probably didn't have to give consent for that, but when you're pregnant, so you have to be blood grouped. And I've been wondering why you said why wouldn't you?
Yeah.
So essentially, why don't we just get the blood group team to do the R1, R1 test on every pregnant woman? That's 600,000 at a stroke. I don't think we actually probably need consent for that. We don't take consent for blood grouping. We just sort of put on your file your blood group A positive and don't give this lady or her offspring gentamicin. I know, I'm sorry, John, it kind of puts Gene Drive out of business. But I have to declare an interest since I chair try and pick up and make point-of-care devices. But that's not why I'm saying it. I mean, I just think that anything that would replace point-of-care, I think John would agree, anything that could get it industrialised
Yeah.
at massively low cost and done across the board, and like no one would complain.
No, we're waiting for people to be sick, aren't we? And you want
So
to do
Emma,
preemptive
why
testing.
don't we just do that?
So I think it's an amazing point, especially when you talk about mitochondrial inheritance, because it's such a clear pattern. And I've been working with the G2MC to lead a separate group of the family history to look at how pharmacogenomics could be better integrated with family history, because we've kept them in separate silos in ways that don't make a lot of sense, actually. I guess they're simple. If you're testing the mom exclusively for the value of finding out about the kids, and then you're testing all of them, I mean, that would be a lot more than babies that end up in NICU. So I guess, you know, that would be a lot of money that, you know, the babies aren't going to have an indication for the drug in the first instance, most of them, and some of them could very well go many, many, many years without ever getting an aminoglycoside. So I guess that would be the only contra. But I agree with you that I think family history and approach to things, as testing becomes cheaper and cheaper, becomes more and more attractive. And I think there's more basic questions even around that, which is, I'm a general medic. I walk around prescribing aminoglycosides to sick people all the time. Why do we not ask people before we prescribe an aminoglycoside if anyone in their mum's family has ever gone deaf after having an antibiotic? That's free, doesn't cost anything. Why do we not do it? These have been totally siloed, family health history, pedigree analysis, and pharmacogenomics in ways that make no sense at all, but even less sense if you talk about something like mitochondrial inheritance. So it's a super interesting question. I'd love to hear more later, and I think it's an area we could all do a lot more in, honestly.
So very quick,
Very
because
quick.
look, they're gasping.
Because that was the original proposed from Ray Bittner back in 2010, who proposed that as a model. And I think the challenge is, as Emma said, the health economics of it. And as part of a project we have, again, Professor Payne is looking at the health economics of RNR1 testing. And so we want to deliver the model that works best for patients and the healthcare system, irrespective of what technology you're using. The reason that falls down at the moment is just on the scale of testing that you would need to implement. But as technology develops, as it adapts, that may be a model going forward.
So listen, we've established that patients are absolutely critical. Oh,
Sue's just got a comment.
So a couple of comments really, Viv, if I'm still live. First of all, I think the point that John made is really important, and we are looking at, John, and also whether we introduce extended blood group genotyping at birth. So you have your extended blood group genotypes. That's important for our diverse populations. And I think that conversation about aminoglycoside toxicity testing needs to be part of that. The second point I wanted to make, which was about the whole data flows, the unified genomic record will enable data to be available in primary care. And so you won't have to think about it. Patients will get their own PGX result, but then the primary care team will already have it, because if it's tested in the NHS, it will go out, it will be available both to secondary care and primary care. So they'll have it. It won't be the patient showing the primary care team. It will already be there. And as part of the build, there will be alerts for doctors to know, and nurses to know, and pharmacists and everybody else to know that there's a patient that might have a sort of an adverse drug reaction and how severe that might be. My other question, though, Viv, and the panel may not have a chance to answer this, is the point I made in my presentation was we're testing at 40,000 a year at the moment, and the studies we're talking about so far at a small scale. If we go to 1 million, this is wide scale testing, widespread. How do you think some of the things that you've all said might change if this is commonplace? So although this is not going to be as commonplace as measuring, you know, doing your standard testing, blood testing that you use in these and other tests, this will be fairly commonplace testing in the NHS. So how would you change your approaches to take that into account? I'd be really interested to know the path.
okay, very briefly, because you are all gasping. Mark, let's come to you.
I think it would just be better health outcomes for everyone, really. The more you're going to increase the scale of this study and the availability of the results, the better health the individual is going to have. So in my case, let's say the SSRIs, if I was one on a drug which would make me even gain more weight, then I'm going to be in a category of people who might be more susceptible for other clinical conditions which are then linked to obesity. So it's all links together, and that if I am preventing some adverse events, which may also lead to other conditions, then what I'm receiving, if this is going to a large scale, is better outcome for myself and more money available to be.
But are you worried, Sue, about the tsunami that is going to?
I'm talking about we're doing small scale testing.
Yeah.
What we're talking about is really increasing this, and it's making it more commonplace. And it could be done and the data could be gained from a variety of different purposes. It could be derived from whole genome sequencing. It could be done on point of care. It could be done a high volume, high scale panel testing that's very, very cheap. It's just, would you change any of the things you've said as we move to it being,
Good.
from the tens of thousands to the hundreds of thousands?
I think what I would change or add to what I've already said in terms of moving beyond PPIE, and one of my friends that works in a different industry, when I've told them all about pharmacogenomics, said why wouldn't you do it? They've said what you need is not PPIE, what you need is a marketing plan. How are you going to educate, communicate, and bring along the public with you?
That's why I say the
this?
patients are your advocates.
Yeah, so your example of Good Morning Britain or whatever, those are the kind of things and strategies that we need to think about. How are we going to take our public and our healthcare professionals with us along that journey?
But I think that the work that Emma and myself presented, I don't think that changes irrespective of the scale. Yes, your testing approach might change, but actually your models of service delivery, what people want from this as individuals, I can't see that dramatically changing.
And I still think that having your data yourself on your phone is really important, because this kind of thing going through the NHS, it can go through very quickly in some places, but be super slow in other places. And actually, if you've got it on your phone, then it doesn't matter that it hasn't quite reached Barrow in Furness.
Yeah, I think these are things to try to reach scale, right? Like right now, if an oncologist does some testing for toxicity in their siloed clinic that applies to one drug, and then they use that to optimize medicine for one person, I think, we've got no concerns. I think there's nothing complicated about that. I don't think patients object. I don't think, it's particularly useful for them to have that on their phone because it's very siloed, right? So I think these are really future concerns about scale in terms of policy, in terms of access.
And having lots of things and it being preemptive rather than always being...
Exactly. But I think also in terms of health equity and getting uptake across different populations who may have trust problems. We saw not everyone wanted COVID vaccines equally. These are not problems I think we can afford to forget if we talk about population level implementation of any genetic service, even if it's just a medicine optimization tool. And I think we need to remember that probably.
Yeah, absolutely. Right, we are going to have to stop this because, look, they're like fish out of water. So
don't you know we need coffee?
We need coffee.
We need coffee.
We need coffee. Coffee, and we are going to be back at 12:15.
Great. Thank you.
Thank you.
Thank you, Pip.
Welcome back to the next session. I'm Anne Daly, Professor Emerita of Pharmacogenetics at Newcastle University, and I'm acting as chair here. So this is a slightly more formal rather than panel discussion session, but I'm hoping that we will be able to get a little bit of audience participation. So the title of the session is Challenges and Opportunities in Delivering a Pharmacogenomics Laboratory Service. And the first of two speakers is Ron van Schaik. I've known Ron for a very long time. He's a full professor at the Erasmus Medical College in Rotterdam in the Netherlands. And he's really a pioneer of this field, especially in offering a clinical service in pharmacogenomics. Now, I think it is fair to say that the Dutch system has adopted pharmacogenomics slightly more rapidly than we have in the UK. There are some important differences between the healthcare system in the Netherlands and in the UK, but I think we can learn an awful lot from what has been achieved so far in the Netherlands. So I'll call on Ron to tell us his experiences in Rotterdam.
Thank you. It's a real honor to be here and to listen to all the talks already this morning. I'm very impressed, and the way that you are addressing this, I think, is absolutely fantastic. So also, I'm learning a lot. When I started pharmacogenetics in 2005, we just started. We didn't think. So this is perhaps even a better approach. So, and I'm also happy to see that there are so many people here in the audience. It's a Friday afternoon already. And at one time I had a meeting and I had to present, and there was only one person in the audience on the Friday afternoon. It's always a bit embarrassing, but I gave my talk, and the guy listened to the whole talk. And after my talk, I thought I should know more about this person, so I asked, so may I ask who you are, that you're still here for my talk? And he said, I'm the last speaker. So, okay, so yeah. Good, so let's move on. Let's see if this works. Yes, challenges and opportunities in delivering pharmacogenetics laboratory service. Like I said, I'm working at the Department of Clinical Chemistry. I'm head of the department there, and also professor in pharmacogenetics. And let's see what we can do here. So this is the Erasmus MC, the medical center. Let's see if the pointer works. Yeah, okay, so it's the general hospital. Here is the children's hospital, which is attached. We have a specific cardiology, the Daniel de Hoed, oncology center that is located on here. And this is the rest of the hospital, and this is the university tower. Very nicely located. You can see a screenshot from the inside there as well. We have been performing pharmacogenetics since 2005. In 2024, we had 32,000 test requests, which we processed. I will get back to the way we do the testing. We're an International Federation of Clinical Chemistry reference center. Our turnaround time is like 4 or 5 working days. And for specific tests, we have like either 2 times a week or within 24 hours, but I will get back to that. So talking about opportunities and challenges, I thought I should start with the opportunities. And I think the opportunity is quite clear, because we have this clinician that is seeing patients, prescribing them the same drugs, and then, of course, realizing that one of the patients does not do very well on the drugs, has side effects, and the other patient does very well. So this is the clinical problem that we should want to address. And if you look at that, we can go back to that for a large part on the pharmacokinetics. So how is the drug being metabolized? So you can see here on this green line, this is the average patient, and the dosing is in such a way that the blood concentration is in the therapeutic window. But if degradation, if the enzymes in the liver do not work as good as with the average patient, you will have a higher blood concentration and more adverse drug reactions, or higher risk on adverse drug reactions. And if you metabolize much more rapidly, you will have a specific time when you will not have the effective therapy. So addressing this, of course, already mentioned adverse drug reactions, 5 to 7% of hospitalizations are due to that, and I just saw from Sue that it was even like 16% there. So this is something that we would like to make better, and on the other hand, only 25 to 60% of drugs prove to be effective. So that is why we are going to use pharmacogenetics to improve this. Because if you can upfront predict who will have a slow metabolism, you can dose them lower, the ultra-rapid, a higher dose. There will be more blood concentration in the therapeutic window, and because of that, you expect that there will be less adverse drug reactions and more effective therapy. And that's, of course, what we want to achieve. So if we look at the opportunities and go to the laboratory, this is currently what we are offering. This is the request from Erasmus MC, and there are like 25 enzymes for which we think there is enough evidence to offer pharmacogenetic testing at a diagnostic level. You will recognize the 2C19, which was already discussed, the cytochrome 2D6 in there, the DPYD. But we also decided at a certain moment to make it more easy for the clinicians and to offer like a DNA passport for medication. So that's the first one. And at that time, we still had like a basic passport and a more extensive passport. And we, of course, we can do all 25 genes in there, but as indicated already earlier, I think that most of the clinicians do not want the full list. They want like a list of genes, and this one is like adapted to that, to medications which there's a high risk that the patient will get that from a GP. So this is a very limited amount of genetic information, but probably is going to be used. Where if you have more specific medication like the DPYD for oncology, that's not in there. Okay, so for having a good laboratory service, you need, of course, a team. So this is part of my team, the technicians that perform the pharmacogenetic testing. But we also have like a molecular biologist for specific questions to be answered, a pharmacist that we have in our department of clinical chemistry to address and to consult, give consultations about dosing. You need research technicians to look into new developments there. And very important also the secretariat. I have 3 secretaries, perhaps because I need more guidance, I'm not sure, but also because we get a lot of requests and questions from GPs, from specialists, but also from patients about the pharmacogenetic testing. I think that part of the success of Erasmus MC in there is that we're very accessible by either phone, email, or website to have information on pharmacogenetic testing. So is pharmacogenetic testing, how is the awareness of pharmacogenetic testing? We started in 2005, and then we had like 25 patients for which we could do pharmacogenetic testing, and I was very proud of that. And in the year after that, we already had 30, so I thought like, we have a good increase there. But during the years, and you can see that there's a large increase in the pharmacogenetic testing, and like I said, in 2024, we had like 32,000 test requests, which represents approximately 20 to 25,000 patients. So this proves to me that there is more awareness and that clinicians know where they can ask pharmacogenetic testing. And when we did a survey, we also found that as a feedback that clinicians reported that I could help actually some patients that had severe side effects, and now I can explain why these side effects occur. And if you look at the distribution of the tests, you can see that the 2C19 is currently the most requested test, like 30% of our test requests is 2C19. And then we have like 12% for the 2D6, and for the DPYD, which is for capecitabine, like 5%. And this is mainly in cardiology, neurology, and psychiatry. 2D6 is mostly psychiatry request, and the DPYD in the UGT1A1 is in the oncology section. And I think that depending a little bit on the hospital that you're working, you can see shifts in which tests are most frequently requested for. So choices to make as a laboratory, I listed some of them here. The genotyping platform, are you going to use CE-IVD or research use only? What's the turnaround time that you're going to do? Are you going to do individual testing or multiplex testing? Are you going to use arrays or next-gen sequencing? And also, how many genes are you offering and how many variants per gene? So we offer 15 variants for 2D6. There are labs that offer 6 variants, others use like 10 variants. Are you going to offer blood, saliva, or cheek swab? John already mentioned that as well. The turnaround time, is it 1 day, 1 week, or 1 month? 1 month is, of course, from a laboratory perspective, more cheap. But then again, we realize that patients and clinicians may not want to wait 1 month. And I think that 1 is better appropriate, or perhaps even like 1 day. The report, are you just going to report the outcome of the genetic test? Somebody is a poor metabolizer or an intermediate metabolizer. Or are you going to give dosing advice? If the sample is being sent in because a patient is on SSRIs, why should you not have dosing advice for SSRIs there? Are you presenting like a DNA passport, so like a card, whatever, including all the genetic information, or are you going to just give the lab results? And are you going to take requests from the medical specialists and the GPs, or should you also consider direct-to-consumer testing? And then information, website, phone, emails, folder. So these are all aspects that as a laboratory you have to think about. And I have here in red the choices that we have made. Like I said, turnaround time should be 1 week. For a DNA passport, we went for 6 genes. And we're not taking samples for direct-to-consumer testing. We have focused ourselves on the medical specialist. Already mentioned the saliva, of the cheek swab kits. We introduced that in 2016, and I think there was a great success. Currently, like 25 to 30% of our test requests are by this cheek swab kit. The physician can, on the portal, on the website, ask, I want to have a DNA test for my patient. Please send this kit to the patient. We send it to the patient, they take the cheek swab test, and they send it back. We have like background information on pharmacogenetics. We have a manual how to use the cheek swabs and an envelope to return it. And this has been shown quite successful because the patient does not need to have blood drawn, does not need to go to a site to have the blood drawn. And in that way, I think that we have certainly established a means for patients to get more easy access to pharmacogenetic information. Something about the reporting, which I said, do you provide just the outcome of the test? You can see here, so it's in Dutch, but you can see 2D6 genotype, for instance. You should mention which variant alleles you have investigated. Then you say which variant you did find. So this is *4*4, 2 inactive alleles. It's a slow metabolizer. And then here it says something like, okay, the activity of 2D6 is low. Please consult your pharmacist for specific medication if any dose adjustment is needed or not. In case that the physician has indicated, okay, there are side effects of fluoxetine, nortriptyline, risperidone, then the report looks different. So then we take into account the genotype of the patient, and for instance, for the nortriptyline, I highlighted that one, we will say in the report, nortriptyline is being degraded by 2D6, the genotype will fit with high blood levels and side effects, and consider a 40% dosing of the normal dose. And then also indicated for a number of other drugs, there are adjusted dosing available for this genotype. Please consult your pharmacist. Because you have to realize that the dosing advice that we're giving here may not be valid anymore in 10 years when there is new knowledge available. But I think it's important that, that you answer a question. So this is like part of the Swiss guidelines, which were published like 20 years ago. You should answer a specific question there. So now we come to the challenges. I think one of the challenges, or an important challenge, is the healthcare provider. Because if we offer this test as a laboratory, will he indeed order the test? And I have 3 examples to talk about. Like, one is in psychiatry. So when the idea of like antidepressants being metabolized mainly by 2D6 became apparent, we looked in our hospital, and in our hospital at the time, there was a lot of imipramine being prescribed. And you have to realize these are all patients that did not respond to SSRIs with the GP. So imipramine being metabolized to C19 to desipramine, both are biologically active. The 2D6 is the inactivating enzyme. And these patients are being dosed based on the blood concentration. You have to wait 1 week before their steady state. You get the blood sample, you measure the imipramine concentration, then you have to wait, then you have to see if you have to adjust the dose, and in 50% of the patient, the dose needed to be adjusted. You have to wait another week, you take another sample, perhaps you have to wait another week and adjust, and so forth. So usually 4 to 6 weeks before you have the proper dose. And we decided to look for what is the end dose by TDM, by kind of trial and error, and compare that with the number of active 2D6 alleles. And we did find this very nice linear correlation. So if you're a poor metabolizer, you do not have the 2D6 activity here, you cut at approximately 100 milligrams per day. If you have 2 active alleles, then you're like higher. And it's like 30% of the standard dose that you actually need for a poor metabolizer. So we thought that with these data, we could also convince our psychiatrists to use the pharmacogenetics, and especially when we also showed, or when it was shown, that if you use conventional therapy and you look at responders by depression rating after 8 weeks, you could see that if you have the conventional method, 23 to 30% of patients are actually responding. But if you use DNA information, the response rate is significantly higher, between 44 and 50%. So if you do the calculation, that's what we did in our hospital. And to say like, okay, based on these data, you could show that if we would use this to treat our patients, we use DNA information, then we would save, as our hospital, €400,000 per year on patients being in the hospital. And I thought that was a good argument. But the head of the psychiatry at the time said, like, but if I use this, then I have empty beds in my department. And my insurance company does not allow me to take more patients in, so we're not going to use this in this way. So in that way, it was a little bit slowed down. Now, happily enough, that changed. Also, the psychiatry, the Dutch Society for Psychiatry now included guidelines for pharmacogenetics. So you can see, for instance, if you're 2D6 poor metabolizer, amitriptyline 70% of the standard dose, clomipramine 50% of the standard dose for intermediate for poor metabolizer, intermediate 70%, ultra rapid like 150%. So now finally also the psychiatrists in their guidelines have dosing recommendations. And to give you a little bit of flavor on how long that took, we started the pharmacogenetic service around 2000, actually as a diagnostic service in 2005. The Royal Dutch Pharmacy Association had the Dutch Pharmacogenetic Working Group, and they calculated the dosage that you could give evidence-based based on the 2D6 genotype. These were available in 2005. So the good thing is when the Dutch psychiatry guidelines came out, that the dosing advices were exactly the same as from the Royal Dutch Pharmacy Association. But there's 15 years in between. It took 15 years before this reached the clinical guidelines of this specific group. So sometimes it can take a long time. The second one I would like to talk about is the cardiology. Clopidogrel, as I already indicated, is a prodrug, needs to be activated by 2C19. 2% of the Caucasian population and like 11 to 14% of the Asian population does not have the full function of the 2C19. And you can determine that by the genotyping. It has been very nicely shown that if you're a carrier of an inactive 2C19 allele, this is the risk of 1. As you can see, all studies show a significantly increased risk on death, myocardial infarction, and stroke, so not the least of endpoints, I would say. And these were all published in 2009 and published in JAMA, New England Journal, and The Lancet, so also very high-ranking journals. So it would be easy. Test for 2C19. If you do not find any variant, you just prescribe clopidogrel. And if you do find variants, you go to the more expensive alternatives like prasugrel or ticagrelor. And just to see the difference, 1 year clopidogrel is 15 euros, 1 year of ticagrelor is 800 euros. So it's a big difference. And we were very keen to see if that would go into practice. And the European Medicines Agency has added also information there in 2011 saying like, okay, they updated the SPC and they said that there's a variability in the response to clopidogrel due to either genetic variation of the 2C19 enzyme. And that is in section 4.4, precautions. It says in patients who are 2C19 poor metabolizers, clopidogrel at recommended doses forms less of the active metabolite and has smaller effect on platelet function. Very clear warning in there. And I was quite surprised when in 2015 the European Society of Guidelines came out. I was very interested to see what they would say about 2C19 testing, but they stated here, at present genetic testing cannot be recommended in routine clinical practice due to insufficient prospective data. So I showed you the results. Yes, there were retrospective data, but apparently EMA was convinced, FDA was convinced as well, but then still the clinical group says, well, we do not really want to recommend the 2C19 testing there. And that was a little bit of a problem, because then also in the Netherlands, you can either follow the EMA advice and test for 2C19 before prescribing clopidogrel, or you can avoid clopidogrel and prescribe the alternative drug, ticagrelor. Erasmus did that. I said, but it's more expensive. And they said, yeah, well, the test I have to pay from my department budget, and the drug goes from the hospital budget. So, you know, it's so sometimes all kind of other issues are there. Or follow the cardiology guidelines and do no 2C19 testing. Well, especially regarding this one, there was a very interesting paper which I think made a change in the behavior of the cardiologist. It's a Dutch paper published in the New England Journal. And they compared the standard ticagrelor against clopidogrel when 2C19 genotype allows. And if there was a variant, then you go to ticagrelor, but you still stay in this particular group. At first, they were very concerned whether the antithrombotic effect would be the same in these two groups. And they indeed found that this clopidogrel with 2C19 was non-inferior to the standard ticagrelor. But the point with ticagrelor is that it's very good, a very good drug. So you have primary bleeding outcome that you have to be worried about. And then it was shown that the standard ticagrelor has a higher risk of bleeding. So in fact, now you can see that the clopidogrel together with the 2C19 is safer than using the standard ticagrelor, and it's also much cheaper. And after this, we noticed, I'm not sure if this is the reason, but after this, we found that there was a high increase in 2C19 requests, and also now in the 2019 guidelines of the European Society of Cardiologists, It is now to refer to, okay, be aware that 2C19 needs to be activated, that there is loss of function variance leading to lack of efficacy in some patients. Be aware, it still does not say that you have to test. It just say, if you know the genotype, there's a higher risk. But if you know that, then you may want to have that risk taken away and do the 2C19 test directly. So at my lab, we then realized we did all the testing like once a week for economical reasons. We realized that we should offer this test result more quickly. So we're doing now the 2C19 testing every day. So that means that within 1 day, you will have the result there. And I thought that the cardiologist and neurologist would be very happy with this result, but they were now so enthusiastic that they want the result in 2 hours. So I tried to convince them, like, for 10 years you didn't care about this, and but. So you see here one of the 2 point-of-care devices that are currently on the market, and one of these devices is now at the cardiology department where they can do the 2C19 testing near the patient themselves. And like I said, this new guideline for 2C19 cardiology was in 2019. So with the cardiologist, it took only 10 years before it was in some guidelines. So we're improving. Third one is oncology, capecitabine and 5-FU. Capecitabine, a widely used anti-cancer drug. 10 to 30% of the people develop severe grade 3 toxicity, and 1% of the patients actually die of the therapy. So you can see here capecitabine is being converted. The DPD enzyme is important here. It creates an inactive metabolite, and 1.5% goes to the active metabolites. But there are people that do have DPD deficiency, and because of that, all of the capecitabine goes to the active metabolites, and that creates the toxicity. And DPD deficiency occurs in 3 to 5% of the population. There are several alleles. This is one of the most important ones, but there are 4 alleles that have now been seen that they have an increased risk on toxicity, and these 4 alleles are depicted here. These 4 SNPs are depicted here. And we did a prospective study in which we compared the toxicity, the risk of toxicity in a historical cohort, which is shown here. This is the reference being 1. And then have a dose reduction, do upfront genotyping, and have a dose reduction of 50% for these 2 variants, and 75% of the dose, or 25% dose reduction for the other variants. And we've shown in this Lancet paper that indeed you did see a decrease in the toxicity here, and especially for this one is very clear, and also for this particular SNP. Very importantly, we also showed that the 5-FU levels were comparable between wild-type full-dose patients and variant carriers with a reduced dose. So the dose reduction that we applied did not lead to undertreatment. And in 2024, we also published that the overall survival and disease-free survival were comparable if you look at these particular genotypes. So the effectivity of the treatment did not suffer from having a lower dose in there. We also showed that if you use DPYD-guided therapy, it's cost-saving. So it's not only cost-effective, it's even cheaper to do the genotyping in that way. And I think that is also very important. But the most important part of this is that this DPD genotyping got accepted by the oncologists very rapidly, within 2-3 years, even before the study results were there. And the reason was that we have included like 12 different hospitals to participate in this study. That means that all the oncologists were already informed and trained in having a pharmacogenetic test in there and see how they could manage with the results. So I think this is one of the reasons why this was very, very rapidly accepted. So this is also a lesson for us. Now we've talked about all these medical specialists, and already mentioned here was the GPs. So I was very curious to see how many GPs were offering pharmacogenetic testing. So we looked at the data we had in 2021. Then we had 8,500 patients that were sent in, representing 23,000 pharmacogenetic tests. And it appeared that approximately 14% of them, 1,206 request forms, were from GPs, representing like 6,000 pharmacogenetic test requests, 27% of all. And I was quite surprised that so many GPs apparently wanted to know about the pharmacogenetics. And we did a survey there, also looking for which were the drug groups for which most of the pharmacogenetics was requested. And you can see antidepressants, 50% of the requests, then the antihypertensive, 26%, and the anticoagulants, then also opioids, statins, beta blockers, PPI, antipsychotics, so quite a range, but antidepressants really stands out there. And if you go then to the individual drugs, then mainly clopidogrel actually is like 23% of the cases pharmacogenetics was requested for that by GPs. So I was quite surprised there as well. And then you have a mix of like antidepressants, beta blockers, pain medications and others. But apparently clopidogrel is also very much in focus with the GPs if it's about pharmacogenetic testing. We also looked, why did you ask for this test? Then 79% was like for side effects, 27% for non-response, 30% prior to therapy. And this is very much in line with the guidelines that we have available for primary care. Because there we say, if you may have listened to a lecture of Ron van Schaik and you got very enthusiastic about pharmacogenetics, don't use it directly in your GP practice. You know, you're perfectly fine prescribing your first choice drug for an antidepressant. But then if you see side effects or the drug doesn't work, then consider if you should do pharmacogenetic testing. And that's exactly what is also reflected here. We also set out a survey to see what are the barriers that GPs are encountering when using pharmacogenetic testing. And you can see that lack of knowledge is an important factor there. Unclear when to test, lack of experience, unclear which test to request, unclear how to request the test, unclear how to interpret the results are like among the top 5 of the reasons for the barriers. So I think that we should really focus on education there as well. We also asked for what are the sources, where did you get your pharmacogenetic information? And like 34% went to the pharmacist for have additional information, then followed by publication in the Dutch College of General Practitioners, 21%, and the website pharmacogenetics.nl, which is 70% of the people refer to. And in fact, this is a website that I set up at the time that we were offering pharmacogenetic testing because we got many, many questions. So I tried to have this like as an independent national website, having the different labs registered there that perform pharmacogenetic testing, which is in the Netherlands like 16 different laboratories at that time. We have also information for patients, we have news, we have background information about pharmacogenetics, but this one is the most used, which is the tables. And the tables you can see here is called like the clinical relevant enzymes, and here it's on alphabetical order, all the drugs, and the list goes longer, and it shows in the first 2 columns the clinical relevant enzymes. So for instance, for amitriptyline, 2D6 and 2C19 are the important enzymes. So if you have side effects, these are the two genes that you have to ask to be tested. And this one is based on the enzyme. So if you're like, for instance, the 2C9, you can see that these are the drugs that have been metabolized by 2C9. And for this one particularly, there is even a dosing advice available. So if it's in red, then the Royal Dutch Pharmacy Association has a dosing advice available, which is different from the general dosing. And this has been used quite a lot. And if you're interested in that, I have like several of the cards also here. I didn't realize that we have such a big audience, and also I have only hand luggage, so I couldn't carry more. But if you're interested, here are some of the examples listed. And then, of course, we should not forget about the patient, because also patient empowerment is important. So that's why we indeed started an app, was already discussed earlier. So if we get a request for pharmacogenetics, the GP receives a code which he can give to the patient with this particular information on like the different enzymes and the activity there, normal, higher activity or lower activity. It will also explain the patient genotype in relation, like if you're star 17, it will say you have a faster metabolism of the 2C19. But you can also have the list of the different drugs here, stating like, okay, your metabolism for acetylcholinesterol is different, for amitriptyline is different, and if you click on either of these ones, you get more explanation how your genotype is related with the drug there. We introduced this in 2021, so I was a little bit afraid that I would have a lot of angry GPs calling me like, okay, now my patient is telling me about pharmacogenetics, which is in fact a good point, of course. But we did not see that, and I think that is patient empowerment, and it makes sure that you have shared decision making. And it saves the clinician time to explain all about the pharmacogenetics because the patient already has this information. If you would like to try this app is called Pharmacogenetic Profile, so it's in Dutch, but you can change the language of the app to English. And I hope this code still works. I asked for that several times ago. If you have this code and you have like the year of birth to fill this in, hopefully you should be able to also have a look at this app and see what kind of information is in there. Okay, then we have also a challenge on the laboratory part still to deal with. Like I said, in the Netherlands, we have 16 ISO-accredited laboratories, ISO 15189, meaning that we can have a diagnostic service. These are all labs that perform pharmacogenetic testing. These are not the clinical genetic centers. Like from the 16, I think there are like 14 which are clinical chemistry laboratories. We have one clinical genetics center and we have one pharmacology center that is offering the testing. But still the labs differ a little bit in the price per test, the number of SNPs they do, number of genes they offer, the turnaround time, the reporting plus or minus advice, the material which is used, yes or no DNA passport, and also like do they use CE-IVD testing or do they have research use only testing which they have validated to be performed as a lab developed test. So of course having this around, you would like that it's more or less centralized, so or at least harmonized. So I started this network clinical, it says like network clinical pharmacogenetics in the Netherlands, and I organize like once a year a meeting in which hopefully all these labs participate to see what are the differences, and in that way try to harmonize as much as possible. One example, of course, suppose you have a patient with side effects of nortriptyline. If you go to this particular lab and they test for star 2, 3, 4, 5, 6 and the duplication, you may find that this patient has 2 active alleles and is a normal metabolizer. However, if another lab, like our lab, is testing on more variant alleles, you may find that this patient is actually a star 17 intermediate metabolizer. Because you have to realize that star 1 is a kind of default value. We did not find the variants we were looking for, but if you look for more variants, you may still find there's a difference. So as a national initiative, and being all labs that have started this, we try to harmonize as much as possible, because in the end report, it will just state you're 2D6 normal metabolizer or intermediate, but you have to know what was tested. So this is one way to harmonize that. We also started there for Association of Molecular Pathology, an activity to have like recommendations for clinical testing, for instance for 2D6, but there are several other enzymes as well. And we said, okay, we will define tier 1 and tier 2 alleles. So tier 1 alleles is the minimal set for clinical testing, and that's based on well-characterized effect on enzyme function, a minor allele frequency in more than 1% in a population, so not just the Caucasian population, and having publicly available reference materials. So for the cytochrome 2D6, we came out as these 15 variants that we think that you should test if you are offering 2D6 genotyping as a lab. So I did a survey among these 16 labs that are offering pharmacogenetic testing, and then I have highlighted the ones that are indeed in this tier 1 guideline. So these are in red. You can see most of the labs do testing for a lot of the variants, but for instance, the star 17 and the star 29, not all labs test for that. So one of my incentives, one of my initiatives is to make sure that also these labs come up to speed with what is required for 2D6 genotyping. So this is trying to harmonize in a country. And then the last part, we're coming to the dosing and advice, the role of the pharmacist or clinical pharmacologist. The FDA has a very nice list of biogenomic markers. For more than 300 drugs, there is now pharmacogenetic and pharmacogenomic information available in the drug label. And that table looks more or less like this. You can, for instance, look at amitriptyline. Therapeutic area is psychiatry. The biomarker is 2D6. And the labeling section is here precautions. But it can also be in indications and usage, or as a boxed warning, or in clinical pharmacology. And you see a little bit what is the problem. This pharmacogenetic information can be anywhere in the drug label. And when I was in Washington, that's quite some time ago already, and when the FDA was explaining this and to see in which section pharmacogenetic information would be, somebody got up and said, well, I'm a GP, you do not really think I have time to read all the drug labels. And I thought it was a good point, but I can still see the other guy standing up on the other side of the room and said, I'm a lawyer, I can tell you we do have time to read drug labels. So this is a problem, and the solution is quite simple. That's called the pharmacist, because the pharmacist knows what is in the drug label and can also advise on how the drug dosage should be adjusted. So I think this is a very nice collaboration between the specialist GPs and the pharmacy. So that means that we have to train pharmacists. So this is in 2017. I'm here with my colleague from Leiden University Medical Center. We had a little classroom of 1,500 pharmacists who we taught about, who we give a lecture on pharmacogenetics for a whole day, hoping that this will catch on. And we do repeat this kind of events. We have like e-learnings, we have publications. So we have every time we come back to this, having all this information available for pharmacists so that they can indeed give advice to the GP or to the specialist there as well. Because in 2000, this was the joke in the New Yorker, can you go with your pharmacogenetic information or your DNA information to your local pharmacist? And in the Netherlands, since 2005 already, this is possible. Because we had this Dutch pharmacogenetic working group which has evidence-based dosing guidelines. And this is accessible for every pharmacist in the country. It's a national initiative. So 15 people which are in this group. I'm one of them, a very mixed group there. And we go through all the literature in a very systematic way, rating the evidence and rating the clinical effect. And if that is enough evidence and the clinical effect is sufficient, we'll calculate what should be the appropriate dose. And like I explained, it's for every pharmacist in the country, so I thought at that time I should check that for you. So I went to my own pharmacy at that time, small village in the center of the Netherlands. I went inside and I said, okay, I'm depressed, I come from my imiprimin, but I'm a 2D6 poor metabolizer for educational purposes. So the guy went into his computer, and then you can see the screenshot here. It says from the Royal Dutch Pharmacy Knowledge Bank, it says 2D6 poor metabolizer imiprimin, and somewhere here it will state that I need only 30% of the standard dose. Every pharmacist has this information. I can go to any town, any village, any city. I have the information, and I get the same advice up north in the country, in the middle or in south, which is, I think, also good. That's why it's important that it's a national initiative. The only thing is that I had to tell him it was in his computer. So I said, what? I said, you can look that up in your computer. So he learned something from me as well there. Okay, but he had it. And then again, like Sue already indicated, he has information on all these drugs. You can see these are the actionable ones, 60 drugs, 18 genes. And for all these drugs, you can see that these are the relevant enzymes in column 1 and 2. And if it's in red, then we have an adjusted dose based on the genotype. So looking at all this, like this is like all these genes, should you now have like this information up front? Should you already go for like a DNA passport or not? Should we test per gene as if we have been taught always, only ask for the test which is relevant for your patient at this moment? Or should we be more economical and go for panel testing like preemptive? And I really do not know the answer yet, but this is something that is an ongoing discussion. And especially since the PREPARE study came out in 2023, showing in 7 European countries and 8,000 patients that you had 30% less adverse drug reactions when using a 12-gene DNA passport for medication. So that means that I wondered, like, okay, if I have indeed this DNA passport, can I indeed go to my local pharmacist? So this is not my local pharmacist, this is Erasmus MC, because I thought I should also check if my own pharmacy knows what to do with the DNA passport. So I went inside, I said, okay, this is my DNA passport for medication, I'm depressed, you know, I come from my imiprimin. She immediately went into her computer, and you can see here the screenshot saying, like, imiprimin, poor metabolizer, lower the dose to 30% of normal. And I told her, I gave her a compliment, because I think it's very good, because your colleague last time, I had to tell it was in his computer, and then she said, but I attended your class last week. And I thought this is exactly the point that we have to do. Sufficient education that people know what's going on. Almost there. This is summarizing.
Okay,
yes.
Okay. 2 minutes.
So challenges and opportunities of delivering pharmacogenomic laboratory service. Opportunities, there's a medical need, diagnostic tools are available, and evidence-based dosing guidelines are also available. The challenges we still have, to have the pharmacogenetic test indeed be ordered by clinicians, or to have it into guidelines, does not need to be the same. Education of healthcare providers, I think, very important, and harmonization between laboratories is also very important. And you may realize that one important part is missing here, and that's about reimbursement. And the point is, in Netherlands, it's reimbursed, so that's not an issue for us. But I think in other countries that could still be an issue that as a challenge, that could be covered. So hopefully this clinician, when I come across him at the coffee machine, will now immediately say, I should order a pharmacogenomic test, being aware now that it's around. And if he does not know enough about that, then I invite him, and also you, if you want to know more about pharmacogenetics, at the European Society of Pharmacogenomics and Personalized Therapy Congress in Rotterdam in November 5 to 8. Thank you very much for your attention.
Okay, thanks very much, Ron. Before you go, we have time probably for just one question from the audience. I promised some audience participation. So hands up if anyone wants to ask Ron a specific question on what he has told us.
I'm right on the opposite side.
Oh.
Ah, Mark. Good to see you.
Just thought I might be able to help with the question that you had around whether doing specific genetic testing or panel testing.
I have to talk a little bit louder.
Can you hear me now?
Now
A
I
bit
can hear
better?
you, yes. Yeah.
Yeah, I just thought it seems like from the conversations that we had this morning around patient empowerment and giving people access, and also the data from the PREPARE study around 30% reduction in pharmacogenetic testing before the drugs being prescribed. It seems like it would be quite clear to answer the question on whether we do reactive testing or preemptive testing. It seems that preemptive seems to be a little bit more of a benefit that we would be getting, and then potentially looking up to whole genome sequencing so that we have a full data set that we can keep coming back to and reanalyzing. So what would be the difficulty of moving to panel testing or whole genome sequencing first?
Okay, so that's quite a question that you put there. So if you go for whole genome sequencing, okay, it's more costly, but you have a lot of information. I'm always a little bit worried there that if you find variants which is not described in literature, what is the clinical consequence? And I know that in Clinical Genetics Center, you just report we found a variant of unknown significance, but then I think then you have the healthcare provider to deal with that problem. So I think that we should just focus, for me at least, just focus on the variants that I know what is the effect and how we can have an adjusted dose. So that's for the whole genome sequencing, but I think that we will go absolutely in that direction. Your other question is like the preemptive testing. Shouldn't everybody have a DNA passport? Should it be at birth? Should it be when you turn 18? Or the thing I think is the first time you get a drug prescribed for which pharmacogenetic information is important, then you go for pharmacogenetic testing. But while you do that, then you may just as well define as a DNA passport. And if that's 6 genes, 12 genes, or 30 genes, we still have to discuss. But I got a lot of feedback, like last week when I was also teaching for GPs. They said, I don't want 30 genes. I want a limited amount of genes for which is relevant for the drugs I'm prescribing in my GP practice. So there's also, whereas as a pharmacist, you may say, okay, but I just want all the genetic information to be able to prescribe the drug for any drug during the lifetime of a patient. Because that's one point I forgot to say. If I go back to my pharmacy 5 years later for my metoprolol, it will give an automatic warning that my metoprolol should be adjusted. If you register now my genotype, there will be, for all the drugs in the future that I'm being prescribed, there will be an automatic warning in there as well. So the preemptive test, I hope that at a certain moment, and that's really my belief, that we shouldn't talk too much about cost anymore. Sorry, Sue. But I think at a certain moment, I think it's not ethical anymore not to use the information that we currently have available. We're prescribing drugs to patients, thereby exposing them to a certain risk, and we have the knowledge and the tools to reduce that risk. And of course, that should be within specific financial parts there, but I think that we should really work to get that available for patients. Thank you for your question.
Okay, thank you very much, Ron. That's a very good answer, a very comprehensive answer. And Ron is here for the rest of the day. And in fact, he's spending the whole weekend in the lovely city of Newcastle. So you can speak to him later. So our final speaker before lunch this morning, or this afternoon, is Dr. Emma Howard. Now, Emma is a graduate, a primary degree graduate from Liverpool, who then went to Manchester to do her PhD. Now, after a couple of years as a postdoc, she joined the NHS in 2001, and she became head of the Northwest Genomic Laboratory Hub in 2020, and essentially has very appropriately, given her academic background, has merged the Liverpool and Manchester labs. So she's going to talk to us about her recent activities in the area of implementation.
Thanks, Phil. Thank you. And thanks again for asking me to speak today, and a hard act to follow with Ron, with their setup in the Netherlands. So, bear with me, we're a little bit behind the curve. I suppose the talk that I'm going to give is broken into two parts. The first one, I'm going to detail some of the standard of care NHS diagnostic delivery from a couple of our assays and go into a bit of a deep dive there, because I really want to demonstrate that sometimes people say to me, the lab is the easy bit, it's everything else. And actually, from where we sit in the lab, it's not the easy bit. And even though it's a non-complex assay for us, pharmacogenomics, it's still quite involved. And I want to articulate that to you today. The second part, I want to look forward. So I want to look, like Sue said, how do we scale? How do we get to the heights? How do we do what Ron's doing? How do we do it on maybe a preemptive setting? And how do we get to that from a laboratory perspective? So it's very much focused on diagnostic, standard of care delivery for pharmacogenomics. So just to set the scene, and introduced it very well in that I am the scientific director over the Northwest Genomic Laboratory Hub, 7 hubs in England. We're in the Northwest. We've got 2 sites. I merged those. We part of that merger in 2019. The largest site's at St Mary's in Manchester, and we rent space in the Liverpool site. So all the staff are employed under Manchester Foundation Trust, who is the lead provider. And just to sort of understand how the work is proportioned, the St Mary's site is the high throughput site where the majority, if not all of the NGS is now done, and the array service. And the Liverpool site takes on sort of cytogenetics, more like where there's no batching required, hem-onc, RD, core RD services in molecular, but also their niche area is pharmacogenomic delivery. So all of the standard of care NHS is done out of the Liverpool site, and we serve a population of about 13%. Sue mentioned the National Test Directory, and here it is in all its glory. This is the predominant part on the table at the top is the cancer test directory, and that's where the DPYD the hotspot sits. And you can see it's detailed for a number of tumour types. And then we've also got these other 2 that Sue mentioned as well. One is for mavacamten, so it's for obstructive hypertrophic cardiomyopathy, and that's CYP2C19. That went on the test directory in January 25. And then we've got the mitochondrial one. I'm just going to focus in today on our service delivery around DPYD and CYP2C19. So, just starting with DPYD. When we set this up, we were probably the first GLH in the country to do so, and we did it in a pilot phase before it was commissioned on the test directory. And we really did develop it from scratch. It was very much, how can we do this? How can we work with our local cancer hospitals to make this work? And not just about the testing, but it's actually getting the samples to the laboratory in a timely way. How do we put those logistics in right from the start and build that infrastructure? And we started with the Christie, and we had really good engagement. It was actually Bill's wife at the time, Fiona, that helped with this. Yes. I should say she was our cancer lead at the time. So thank you. And yeah, so we worked with the Christie to do that. And we developed an SOP around that pathway. And it worked really well. And then we rolled it out to get to Clatterbridge as well. So for those that don't know, and we spoke about this today, DPYD testing is a reactive test, and the NICE guidance back in 2020, I think it was now, recommended that it was tested up front for any prescription with fluoropyrimidine chemotherapies, such as 5-FU. About 12 to 30% of patients experience severe toxicity, and this is because there's a DPD enzyme deficiency that can lead to that. And, you know, heterozygotes in there, so if you have one variant, then requires a reduced dose, and if you have 2, if you're homozygous or a compound het, then you could have severe neutropenia and would need a different chemotherapy, or it can actually result in death. There is an antidote, it's very expensive, so you know there's a real driver here this is a very reasonably priced test to make sure that those adverse events don't happen. Just to give you an idea of what we currently are receiving and delivering, we do about 425 currently of those DPYD tests a month. We deliver it by LAMP technology. This is a loop-mediated isothermal amplification. The benefit of this technology and why we chose it, it doesn't require DNA extraction. It does require a blood test. So that blood comes in and we do a lysis prep of it. And that means that we don't have problems with storage. So we don't store those blood samples. We keep the blood sample until the LAMP test's done. Once we know it's we've got the test result and the report goes out, we routinely dispose of that blood. So we've not got this long-term storage problem. Because I don't know if you know, we've got to keep samples for 30 years. The FLC path guidelines very clear. If you extract DNA, you keep it for 30 years. It does lead to long-term storage archive problems in a laboratory. It's fast cycling, that's why we chose LAMP. It's highly sensitive. And we work to a 5-day turnaround time, but we averagely turn around in 1.3 to 1.8 calendar days. We currently assay for these 4 variants, which are just the common ones. We are working on new assay designs to add new variants to it at the moment, and Vicky, who's my deputy, is working with different companies to do that at the moment. Just to detail the just to give you an idea of how long it takes in the laboratory, 4 hours probably start to finish. Like I say, blood lysis, no need for DNA extraction, a couple of hours, robotic setup, quite hands-off, another bit of robotic setup, onto the machine, which is the Quant Studio, off the machine after 15 minutes, quite quick. This is what the results look like. So we've got it gives you a melt curve plot. So you can see the normal allele has a different melt curve, different temperature that you see the peak at. Likewise for the variant allele, that's homozygous. And then we've got a heterozygote at the end, just to show that that's the sort of results that the lab team get. We've automated that as much as possible. So what I'm trying to demonstrate is, we're up against time here. We've got to make that process as slick as possible in the laboratory. So when that genotype comes off that machine, it's populated in this way. It's an automatic pull. There's 4 patients on here, 4 different variants. When you see the check there, that's a normal control. And then you've got the 4 positive controls in there as well, automatically pulled. We've also gone to batch reporting. So that means for normal genotypes, they do mail merge and they're out. And we've gone to single signature reports as well to speed up that time. All reports are sent to a centralised email address. And that was key for when we set the pathway up. We don't want those results going back into individual referrers to sit in their email box. They need to be acted on quickly. So we work with the biochemistry team in both Clatterbridge and the Christie, and it goes to a centralised email address. We also, if there's a positive, we phone that through. So it goes out by email, the admin team get on the phone to alert them that there's a positive that needs acted on. Some of these patients are inpatients, and the results are acted on very promptly. So before I flick over, that's an example of report at the moment, and I will come to this. We're still on PDF reporting, even though we're on single signature. It's still cumbersome, and we need to move away from that if we need to scale. So turning now to CYP2C19, like I said, we're currently commissioned to do that centrally, and that was from January 2025. But we actually did a pilot with Bristol Myers Squibb for a year before it went on the National Test Directory. We delivered that with Dundee, so we were the only provider in England at the time. We're now delivering for half the country for the mavacamten drug, which is a cardiac drug. And then on top of that, we layered that CYP2C19 testing for the clopidogrel pilot, working with the Network of Excellence. And, that required 3 different trusts, which are Doncaster, St George's and Royal Devon, and Salford with point of care. So there was comparison data there. And, I'm not going to go into too much detail here, but for that, we've tested combined with the mavacamten, over 1,016 patients so far. We deliver this also by LAMP, and the standard turnaround time is 5 calendar days. And you're probably aware that obviously clopidogrel is a blood thinning drug, and for patients with strokes, it can be less effective depending on the genotype. Example of a mavacamten report, again, it's a PDF, and you can see we test for the 3 common variants there. So look, just homing in on the trial, on the pilot that we worked with the Network of Excellence, the number of samples taken so far were 468, although we only tested 424. It's a 9% mismatch, and some of that's because, they decided not to be tested or it didn't come to the lab. I will say that there's been, I think when there's a pilot, the difference between the DPYD when we set that up in a pilot, because they knew that it was going to be commissioned, was taken far more seriously in terms of the logistics. So the pathways from the pilot sites in the clopidogrel, I don't think have been firmed up in that getting the sample to the lab is really important, because the time lag is not within the laboratory. A lot of it is when you look at the audit data, it's receiving the sample. So, it's that engagement up front that's really important. Just to compare the results, you can see that DPYD and CYP2C19 from the laboratory, and year on year we've increased the number of tests for DPYD. And you can see that on the far side there, you've got the compound hets or the homozygotes, and they're the people that would have been severely affected if they'd been given 5-FU up front. And then likewise for CYP2C19, so you can see these patients that are really benefiting from these tests. And it's not that simple. So challenges to the current system. We've talked about the paper referrals. You know, we really do need to move to electronic ordering. The pace of referral, like I said, from the centres, transport arrangements, all matter. This is an end-to-end pathway, and we're just a small component of it. So we need to work on that. Obviously, I've showed you an assay that's quite automated, but it could be more. The high volume does require further automation. And we talked, I know Ron mentioned about adding variants, and that's really difficult as well. You might use a CE marked assay. You can't just add variants. You've got to validate the test again. You can't, you know, so actually knowing the variants from the start that we need to have the whole picture to design an assay is what the lab absolutely needs. I mentioned the PDF reports. I'll come on to the informatics side of it because the integration, we've talked a lot today about the patient having that information, whether it be in the NHS app. You know, if it's the EPRs don't speak to the GP record populates the NHS app now, but if it's secondary care where these tests are ordered, it doesn't go in. So, you know, in a lot of the upload, I know from the Christie, for instance, you know, we email those results back and they manually upload from biochemistry into biochemo. You know, it's not an automatic thing. And I said before, delays in pathway. But the other big thing is the cost. So we know there's a tariff price for this on the National Test Directory, and you know we need to come in. Reagents are really expensive. We're seeing year-on-year increases, and to come in under that tariff price is also a real challenge. Yeah, and this was one of the clinicians actually in the pilot, and Vidal know this. Is if you get rid of the paper form, it might be workable, maybe. You know, because those things really help people, and it's that wraparound infrastructure that needs to be in place if we're going to scale. So the second part of my talk, I just want to look forward at the forward strategy. And Sue mentioned before, that's the aim. So by 28, 29, we want to see, and the anticipation is that we'll be delivering 2 million tests, genomic tests within the NHS. And a predominant amount of them is perceived to be going to be pharmacogenomic assays. So what do we test? So I think there's this question at the moment, we're doing this little bits, you know, it's quite high volume of reactive tests, as in those in the lab. And this talk of adding new variants to those, I know I've spoken to Munir about some of those as well. But that adds a complexity to the lab because you can't just make that change. And then we've spoken to the national team recently about these new targets. Is there a tipping point for this, that we're just adding individual reactive tests for single genes? And at next point, should we not just be doing a panel? Because when you add so many on, wouldn't that be a better, more efficient way of dealing with it? So that's in the reactive setting. And what about preemptive? When are we going to switch to that? You know, because then you can do a panel up front. Are we testing everyone in A&E? Testing everyone in hospital? Are we going to test certain age groups of people? We're already adding these targets that we know of and we need to do to our exome, but when do we report them? Can they be acted on? Are they going to be in a separate box? What does that look like? We've talked about whole genome sequencing. Yeah, it's all doable. And I know Ron said, you know, you might get incidental findings, you might not, you've viewed these, but we can tailor the bioinformatic pipeline to just home in on the ones that we really want to assay. And we've also got the next generation study in England as well, and should we be putting those pharmacogenomic targets on that now? So we're building it up from bottom and coming down from top and adding it and keeping the reactive stuff going. So it's like a multifaceted model, and you can see it's actually quite carnage for a laboratory who's trying to build a strategy. So it's not that simple, the laboratory side isn't. And then Ron touched on also, you know, how do we test? There's a lot of variants here, and not one workflow fits all of them. And that's the thing, and I think Viv said before, keep it simple. And that's what we want to do in a lab, because that makes it fast and that makes it efficient. So how do we keep it simple when there's so many different variants? So you've got your arrays. We're using the LAMP technology, LACAR. You know, it's CE marked. We've got Thermo Fisher, who basically have custom assays that we can customize or off the shelf. We're working with APIS at the moment to look at multiplexing different things. We've got our Regina platform that we deliver the progress study on with the network of excellence. But again, it's not that scalable, and it's quite cumbersome in its analysis. And then obviously we've got the next generation sequencing. And at what point do you tip that threshold that you go, actually, we should just be sequencing, and we should be doing it in a preemptive setting. And so I think from where I sit, it's going to be phased. I think we will keep adding the reactive. I personally think we should be doing a small panel for those reactive tests now, and then planning for the preemptive and where do we go. But from the lab, and I think I've made this very clear, I don't want to extract. I want to store all this DNA. I want as simple as possible workflow. And like I think I've articulated, not one workflow is going to meet, so it might be one or two, but we just need to get to that. One of the big things we've been working on in the Northwest, mostly focused on LAMP at the moment, if I'm honest, is an automation business case, working with a couple of companies to scope out how could we do this in a really automated setting, using robotic arms with our existing instrumentation to just automate the process. And we've got some figures. We asked companies to model if we needed to get to 300,000 tests. What does that look like in terms of staff? And if they said, if we did that over 7 years, in 7 years we'd need like 7 whole-time equivalents just in the laboratory. But if we used automation, we'll need 1.5. The space is a massive issue. Space in the NHS is at a premium. You can't just layer on layer more and more staff onto a workflow, because that's what you need to scale. So this literally reduces your space. You can do it in your existing footprint. And yeah, so this is a business case that we're writing at the moment. That's gone to Trust Board, Finance Committee next week. And it is adaptable. We've worked with companies to say, actually, you know, we're not stuck with a LAMP workflow if we put something like this in. So also reporting, and we talked about that quite a bit today, about, you know, we've got to move away. From the GLH perspective, we've got to move away from these PDFs. It's what we've done. It's long-standing. We're good at it. But actually, it doesn't meet the need of pharmacogenomics. So I've screenshot, and I think we mentioned direct-to-consumer test. That's the 23andMe. That's actually mine. So I need a lower statin dose. But they do a very simple interpretation. It's really nice. So I think we can learn from how we can represent that in apps or EPRs that makes it easier for prescribing. So I think Vid said, and you've really like sort of, pharmacogenomics only testing is only useful if it can inform prescribing. It gets to the right place to be acted upon. It's all right the lab doing these tests, but if they just sat there and nobody knows about it or no one knows how to react to them, then they're useless. So we also need to receive the test electronically, and I know the national team are working on the order comms, which I believe is not far away, some beta testing very soon, so that would be really well received. But then actually, what is our strategy about GP returns, EPRs, unified genomic record? How are they going to speak to each other? The NHS app, all these systems, we need a system alerting as well. If, you know, they're going to flag when there's a prescription change or a dose reduction. It does require new infrastructure, and that requires new investment. Part of what the Northwest are doing is looking at that integration, and again, working with the network of excellence to just say, how can these engines talk to each other? These are our sort of laboratory databases, and they need to be integrated as well. If we could get everything talking to each other and integrated, it becomes a lot slicker. So that's a piece of work that Scott, who's here today, and Jan, who's our informatics and bioinformatics lead, are also working on. So where do I see the next step? So internally, we've set up a pharmaco strategy steering group with the network of excellence. So John's on there and Vid, and we meet regularly to sort of thrash out, you know, all of this that I've described to you today, the variants, the genes, you know, what activity levels are we aiming at? That's another big thing. You know, I'm scaling year on year. I need to know, because you need to build your laboratory to be able to deliver it. The automation investment is massive, and I know the national team have got the spending review in about that, so we're really hopeful that having a business case that's tracking ahead of that, you know, may see that we can get that into place. Test reimbursement tariff I talked about. What does that look like if we start doing a small panel? Can we afford it? Can I come in under that price? Order comms, like I said, electronic reporting integration is absolutely critical to getting these results back to patients in the right format. And I've spoke a lot about the challenges. But I do think where we are, and we've done very well in the NHS as we built the genomics, and Ron said today there's a lot of positivity around it, is we've got a real opportunity to work together with the national team, with the networks of excellence, to really build a pharmacogenomic testing service for the future. And I'm sure that we all agree that's what we're all here today. And there's such positivity, and we can learn certainly from the Netherlands and your panels and things like that, that I just think that, you know, it's for us to shape. So thank you.
Thanks very much, Emma, for covering a great range of challenges. A question or two from the audience for Emma before we finish? Yes, here?
Hi, I'm Jackie O'Brien. I'm working on this CPGX project, but also chair the Industry Pharmacogenomics Network. I have a question for Ron, which I can come back to offline afterwards, but about the harmonisation of bringing labs together and having those conversations. But for the purpose of this presentation, I noticed you've got a huge number of work packages. You've got a huge amount of work to do. We have a very positive medical device industry for pharmacogenomics in the UK who really, really want to work with the NHS and align with the NHS and support you find some of the solutions that you're looking for. How do we engage more closely with you, and how do we ensure that we can be part of the conversations when you're making those decisions?
Yeah, so absolutely, we're happy to work with people. So if you just contact myself or Vicky, and we can bring you into some of those conversations that we've got within that steering group that we've established. There's different branches of that, you know, we're talking to different companies about assay design, we're working with them, perhaps being beta testing sites. So yeah, please just get in touch and we'll have that conversation.
Thank you.
Yeah, I would suspect you probably also need to talk to Sue.
Yeah.
If you're not already.
Well, Debbie's got a hand up
Yes.
from the national team.
Just in the absence of Sue, if I can just come in, there is an absolute intention to work with industry, and Sue did mention right at the beginning in her opening speech there was a collaboration between ABPI, MRHA, NICE, etc., and bringing those in. That's quite burgeoning at the moment, but I'm sure they'll be very welcome to have this conversation about pharmacogenomics at a national level and bring you in.
Okay, final question from Ron, please.
Sorry to make you run. Okay. Yeah, just I was intrigued by the positive point that you pointed out with the technique that you're using, the lab.
Yeah.
Because you do not have to store DNA. So I can see that it's an advantage, but from my perspective, I was always a little bit, perhaps I'm too afraid, but I'm so afraid that I will do the genotyping now, and then 10 years later, another lab will do the genotyping and will come up with another result.
Yeah.
And then the question is, did I make a mistake at the time? Or did the new lab make a mistake? Or is technology further? So I'm always very keen to go back to the DNA, which I had, that I could at least with the new technologies that are there confirm, hopefully, that I was right in the beginning. So perhaps I'm a little bit too afraid of liability there. But that could be a positive thing of storing samples there as well. Yeah. So how do you reflect on that?
No, you're absolutely right. But what I will say is we've had a bit of an incident recently, and even though we've got the DNA, we can't replicate the test because, and it's not in pharmacogenomics, by the way, because I haven't got the primers anymore, and I can't replicate because I haven't got the PCR machines. So you're right, it does mean that we can't go back to the original sample, but sometimes you just can't replicate it anyway, you know, because you're 20 years down the line. So we did take that decision. We spoke with all the labs about it, and it is only the pharmacogenomics that we do it for. And I think a lot of it was because, as well, there's no predictive testing for it, so there's no family member testing, so we would never need it as a positive. So that came into the decision making too.
Right, wonderful. Thank you very much. I must say that it's good that, unlike Ron, I've got more than one person in the audience still. So you've done very well on a Friday afternoon, but the level of engagement all day has been fantastic. There's been great energy. I think it's been really nice to hear different perspectives, to have sort of combination of talks, of panel discussion that we had, and then the workshops. I think that's been really nice to sort of have different ways of exchanging ideas, listening, understanding and learning. And, you know, just now I was sort of sitting looking at the panel and thinking, gosh, you all come from different sort of health professional or professional backgrounds. You've all got loads of different experience and loads of skills, and you're sharing and talking about them. And that's something that I think is really wonderful about the whole network that we've really seen develop over the last couple of years. And as we heard earlier, there's going to be more network. So that's really great. So, you know, the fact that Sue, in her talk earlier, gave the commitment to this network going forward. So, as I said, we really are keen for you to come forward with your ideas about things that you think we should be addressing, things that we've already discovered, learned, that we can make better, and some of it's about scale. And just, you know, as Ron said, just doing it, you know, just getting up and doing it. And some of that's right, because it's only when there's real elements about thinking about things, designing stuff, working hard to craft something, to do it and deliver it as well as you can. But ultimately, you've got to do some stuff as well, because then you iterate back and you learn from that, and then you keep improving and you keep trying to make things better. So it's really important to thank the people who have made today possible. Obviously, all the speakers and the people who facilitated the groups and contributed, the people like Barbara, Alison, Lisa, Jack, and the team with Emma in Newcastle, who have made us so welcome. It's a great venue. The whole setup has been fantastic. And then also, you know, just all the logistics about getting the information out to us and all of that sort of stuff has been fantastic. Please do give us your feedback. We're very keen to hear what you thought of the day, things that you'd like to see more of or whatever, and register for the next meeting in November, 13th of November. We're pulling together the programme now. It's still at a very embryonic stage, so if you've got ideas, let us know, because we've got some things that we want to do. There'll be an update on the CERSI program that you heard about earlier from that Meneers leading in Liverpool, which will be great, and a couple of other ideas that we've got as well, but there's still room in that program as well. So have a safe trip home. I see the sun shining, hopefully not just in Newcastle, but in the rest of the country. Have a safe trip home and enjoy your weekend and carry on pushing forward pharmacogenomics. Thanks so much.